afternoon, everybody. I recognize a lot of familiar faces. Thank you very much for sharing your Saturday afternoon with us. And do we have a treat for you guys? So first of all, on behalf of Doctors William Padula, Toby Mendelman, and myself, Linda Ferguson, for people who don't know me, I'd like to welcome you to our grand rounds. But first of all, we'd like to have a little word from our sponsor, Jim Siller from Nikon.
Hello, everybody. I promise to be very brief, so welcome. Some of you may be wondering, why is Nikon sponsoring an event like this? But one of the things I wanted to bring to your attention is that Nikon not only makes cameras and wonderful camera lenses and optics and all kinds of other optical devices, they also make lenses for your glasses. So I'm here today representing Nikon optometry, so Nikon lenses for your glasses. And we work very closely, and we've worked from the very beginning with Dr. Mandelman here locally with some of what you're going to hear today in manufacturing the lenses with the prisms for these patients. And also, just as a side note, for your patients who may experience neck pain, neck strain, back strain from using computers while wearing progressive lenses, where their vision is compromised at that computer distance, Nikon makes the market-leading lenses for working on computers, or that near and intermediate specialist lenses. And they're not available at big box retailers. They're not available at the internet. They are available at independent optical clinics like Dr. Mandelman's clinic and many others throughout the region. So I just wanted you to know that Nikon is an innovative company. This is a very innovative experience that you'll have today, and that's why we're sponsoring it. Thank you very much.
It's like Ministry of Silly Walks going over here. So welcome again to the Grand Rounds. The topic is visual consequences of brain injury with post-traumatic vision syndrome and visual midline shift. And this is going to be a game changer for everybody here. You're very lucky to be part of this, and we're so grateful to have Dr. Padula come all the way from the States to educate us on this. Concussion, which is also known as mild traumatic brain injury, is a very hot topic these days. Will Smith's been in a movie about it. Dr. Simon Walling, our neurosurgeon from Halifax, was on the radio on CBC on Thursday. I don't know if any of you caught that. It's been in the media everywhere. In fact, you probably have patients coming in terrified they have chronic traumatic brain injuries. So it's really a hot topic. So is it a new epidemic, or are we just starting to recognize it better? Maybe the rock'em sock'em hockey and the jacked up football does have consequences. So we're getting better at recognizing it, but what about investigating it? Well, to date, we don't have any blood marker. It's not like troponin for MIs. CTs and MRIs are negative. So the treatment in the medical profession is basically to rest. But my quest to learn is to really want to figure out a better way to do this than just rest these people. So to give you a little 2-second synopsis of my background, I started off with neurophysiology, and I studied at Waterloo. That's how I met Toby to begin with. Went to medical school in Glasgow, where Professor Teasdale taught me about the Glasgow Coma Scale that he wrote. So it was a fascinating time going down to the ER in Glasgow with all the head injuries and having the man himself explain to me mild, moderate, and severe head injuries. But what he was very clear about, though, is this was a neurosurgical triage. So somebody who has a mild traumatic brain injury doesn't really mean it's mild. It's certainly not trivial. They do have brain damage. So that's something we all have to remember, because I think our understanding as a society is, oh, these are mild. You know, it's your bell's rung, get over it. I came back to Canada and studied ophthalmology with Dr. Maxner. And then I switched over to emergency medicine. Must have been all those days in the ER in Glasgow. And Dr. John Ross and Mike Murphy taught me the acute treatment of head injuries with rapid sequence intubation. And then I studied sports medicine with Bill Stanish. And through that experience, I was able to travel with the Olympic and Paralympic teams for 10 years into 4 games. And it was the athletes themselves who really taught me about head injuries. One of the people I met on the Paralympic and Olympic route was a guy named Dr. Mark Lovell. And you guys have probably all heard about the SCAT2, SCAT3. He invented that. He also invented the impact computer test. And his PhD student, Mickey Collins, basically both of them invited me to come to Pittsburgh to see their concussion center. Now, their concussion center is a $1 billion building, and this is where Sidney Crosby went. So there's some integrity here. We Maritimers are quite excited about this. What really impressed me, though, was their multidisciplinary team approach. And they had a specialist there called a behavioral neurooptometrist. And I'd never heard of something like that. I mean, we had optometrists, we had neuro-ophthalmologists. So I asked a lot more, and I spent a lot of time with them. And they taught me about the pioneer, Dr. Padula, and his concept of post-traumatic vision syndrome and how he treated these with prisms and therapy. So I took as much information as I could, and I came back to Nova Scotia, and instead of making a multidisciplinary clinic, I tried to make a multidisciplinary province. And within about 3 months, all of a sudden my patient zero came in, a guy we knew as Derek. He was in his mid-50s, a retired semi-pro hockey player. He was doing hockey camps, and very fit man, 6 feet tall, 250 pounds. He was working as a janitor and mopping up the floor. There had been a leak in the roof, and all of a sudden a soggy ceiling tile came down and whacked him on the head. He fell to the ground immediately, no loss of consciousness, no amnesia, so a lot of the neurologists would basically say there was no concussion. But as he was on the ground, he remembers feeling that the eyes, the visions, it was like he was driving in a snowstorm at night. And when he tried to get up, the floor was really wavy. And he had the usual symptoms, the nausea, the vomiting, headache, dizziness, off balance. So for 2 years, poor Derek went through the medical system. MRI was negative. He saw the specialists. Nobody could figure out what was going on with him. And he was basically cut off from WCB and labeled as a malingerer. So he ended up seeing me. And he came in at a 45-degree tilt, wearing dark glasses, crunched over, very flat affect. And I was kind of very concerned, thinking I don't know how I'm going to help this guy. So I started off with the basics, and of course his visual acuity was normal. But once I started doing some of the testing that Dr. Padula has taught us, I started realizing that this man has post-traumatic vision syndrome. And he needs to see Dr. Padula. But unfortunately, he had a difficult time coming to Truro from New Glasgow. So I thought, okay, he needs to see an optometrist who's going to understand this. I thought, who's the smartest optometrist I know in Nova Scotia? And Toby came to mind immediately. And so I called her up and I said, this is what I'm seeing. And Toby said, well, that's really timely because I just had a lecture from Patrick Quaid and he was telling us about this post-traumatic vision syndrome. I said, well, you have to see this patient. He needs yoke prisms. This is what's going on. So sure enough, she saw Derek, put on the yoke prisms. Immediately, for the first time in 2 years, he could stand up straight. The vision was clear. His stuttering stopped. It was a miracle. So he was crying, Toby was crying. She calls me up and she says, this is amazing. We really need to learn more about this. I said, yeah, we need to get Dr. Padula here. And that's what she did. So without further ado, I'd like to bring Toby to the podium to introduce our very special guest speaker.
We're going to have one introduction still. Before I do my intro, I'm actually going to ask J.R. Marshall to come to the podium as well. Since we're talking to a group of therapists, I thought it'd be nice for you to hear from one therapist who's actually taken Dr. Padula's courses, starting to see patients, and some of the results that he's noticed.
All right, so as Toby said, my name's JR. I'm a private practice physio in New Glasgow at Active Life Physiotherapy. I've been doing concussion rehab and MVPT for about a year now. I sort of got into it in the traditional way you see with concussions. I deal with it from a sports way. I work with a junior A hockey team, AAA midget baseball. Sort of got interested through that side of it. Took the basic courses that were out there at the time, and then sort of heard through Toby, that's where we got into the MVPT side of everything. The biggest thing from a therapy standpoint that I go see with a lot of people, it's definitely the multidisciplinary approach. When people are coming through that definitely will see success. And the other big thing is just how quickly the people can actually see success. You get people coming into you and you can see changes within a session, even though it takes quite a long time with it. One very quick example that I can remember right off the bat was a gentleman that came into me unable to read even an article in the paper without remembering 2 lines behind him, and after 2 sessions he was reading a full newspaper front to back and able to know what's going on. I've had people who come in. I had one that pretty much right away we did some work with binocular occlusion, which is sort of a pre-screening type thing prior to prisms for us, that the second he put that on, all his dizziness was gone. So he'd have dizziness arrest and would bring, as soon as he put the glasses on, it would go away. As soon as he took them off, it would come right back. And there definitely is a lot of things out there that just previously have been missed. There's a lot of people who have been through physio before they come to see us. And a lot of the time they're frustrated, they're annoyed, they're depressed. They've been going through symptoms for a long, long period of time. And the best part about doing the therapies is that in the course of an assessment, in the course of starting to treatment with them, all of a sudden you can see a lot of that starting to go away. You start to show them that there is hope, there is stuff that can come on. A lot of the time it's the visual midline shift that we see is the real big issue with it. And the biggest problem is it just hadn't been recognized in the past. They've gone to a lot of great health professionals, a lot of great doctors, but they're not recognizing this portion to their symptoms. You start working on the shift and all of a sudden things start coming around. You start seeing things like anxiety, depression, all that's starting to go away just because you all of a sudden bring them up right. From a manual therapy standpoint, a lot of people work with neck pain quite a bit, headaches. You see a lot of chronic MVAs that just aren't getting better, and some of them that are underlying with what we now see as some post-concussion or visual midline shift. One of the biggest things, if they've been shifted to the side the whole time, I don't care how good a therapist you are, if visually they're seeing themselves over here, that's where they need to shift. Their body's going to go back to that position. So you start working on some of the therapies, and then other secondary effects can also come away too. So over the year, I've definitely seen a lot of large changes with people, not just in symptoms, but in their whole life, because this is a life-changing effect for a lot of people. It can go on for long periods of time before it gets recognized. And hopefully with this, we'll start to recognize a lot quicker and not bring it to the point for those symptoms. Thank you.
Welcome, everybody. I can't believe this is actually happening. Linda and I wanted to put this together was about a year ago, I think. First time I took my first lecture was about 2 years ago at the Neuro Optometric Rehab Association conference, and that's where I started learning all about post-trauma vision syndrome. And it was at that conference that I learned that there was a world expert out there on this syndrome, and it was Dr. Padula, who was, as I said in the previous lecture, was spoken of almost reverentially by the therapists and doctors who were present at that conference. And I've taken all of his courses online, 50 hours, although more like 150 hours by the time I got through it. And we worked very hard to, when you take his courses, you realize that this is not a therapy that only an optometrist can provide. It does involve, it is multidisciplinary, and particularly involves physiotherapists and occupational therapists. And I couldn't see how I could provide the therapy in my office without aligning myself with these therapists. And this is really new ground for an optometrist. We don't normally work with other healthcare professionals. We are usually, people come in for an eye exam, I give them contacts glasses, see you next year. So we are trying to put together a group that is going to be more cohesive, try to provide these services across the province, as Linda mentioned. And this is kind of the start, is this conference, to get everybody on the same page, make people aware of the therapy that we can provide, and try to provide standard of care across the province, maybe even across the Maritimes. So it's my great pleasure to welcome Dr. Padula. I read his entire CV at the last lecture. He forbid me from reading it again, but it is very impressive. He has published over 6 books and over 40 publications. He's given over 350 lectures worldwide, and he continues to work extensively in a field. He really is an innovator at a time when most of us would be thinking about retirement. He's still working harder than ever and very, very passionate about this subject. And I also wanted to thank again Nikon for their support, because this would not be happening without their help. So without further ado, I'd like to welcome Dr. Padula to the podium.
Welcome. I'd like to thank Dr. Ferguson and Toby. Thank you very much, Dr. Mandelman, for inviting me up here to speak with you today. It's been a great trip and a great experience to meet the professionals of Halifax, Nova Scotia, and beyond. You're doing great work. I've learned from some of the studies about your healthcare system how broad-based region you really are, and you're serving people from great distances. Whereas in Connecticut, it's less so because it's more condensed. But I established an institute there around 2002 because my office was getting too small for me for seeing patients with wheelchairs and coming in with a variety of different types of neuromotor problems. So I created a 6,000 square foot space in another building where I had wide hallways and broadened it out so I would start to see patients that needed to be seen. And interestingly enough, the geographic area expanded internationally. So I see people from Canada, South America, Asia, Europe, Africa. We'll have one woman comes in from South Africa once a year. She'll be in a few weeks. I understand I have a patient from Trinidad, England, and a few more coming in over the next few weeks. And then they're not coming in to see me. They're coming in because they have a problem. And perhaps I have a way of dealing with it. People worldwide are having difficulties with their vision in relationship to neurological events. It eludes doctors and therapists from understanding this because of the very nature of our visual process. And our visual process is such that we think through the visual system. So if all we do all day long is think through the visual system, how do we know that it connects in other ways? Well, you as therapists, you work with vision every day. You work with movement, posture, balance. You hear from patients. And perhaps you're here for the very reason that you've heard from patients their discouragement or their difficulties in using vision in conjunction with their balance problems. Or maybe even some of them have said they have balance problems they're associated with vision. So that's what we're here to explore a little bit. We're going to talk about the consequences of two syndromes, post-trauma vision syndrome and visual midline shift syndrome. We're going to talk about the research, what it was that led me to that research, as well as where do we go from here. And this morning's presentation was primarily to the doctors in the area, and I assume that you're all PTs and OTs. Any speech therapists? Any other disciplines?
Psychology.
Would you say it again?
Psychology.
Psychology, thank you. Rehab counseling. Good. Well, thanks for all coming. It should be an interesting afternoon. I have some videos to show you, and I also have the work we're doing now, where we've developed a new approach called Neuro Visual Postural Therapy. And I'm going to be speaking with you about that because it creates a bridge to understanding the postural base in relationship to the visual process. And once you understand that, what do you do with it? So there's been the more traditional approaches of let's do vision therapy, and that's where I started from. But as I began to understand the visual process better, I began to realize that vision therapy works in a particular area of vision. And when there's a spatial visual processing problem that is also affecting balance and movement, if you work to try to bring fixation and pursuit tracking and saccades, as well as accommodation and convergence, and you emphasize that, you'll increase the problems in the very areas that you're working. So we have some demonstrations with that too. Well, this is the Institute in Connecticut. The Institute is multidisciplinary. We do have other professionals that I bring in. I learned quite a bit about what I do, not directly from someone else, because there was no such thing as neurooptometry or neurovisual processing rehabilitation, as I'm calling it now. I'm using the term neurovisual processing rehabilitation because I was the founding president of the Neuro Optometric Rehabilitation Association, and we coined the name to describe the need for working with neurologically challenged patients through vision. And it became such a catchy tune or word that what happened was there were many doctors that were just saying, yeah, I do neuro-optometric rehabilitation, and doing pencil push-ups or some other type of fixation training. So the reason why I use the neurovisual processing rehabilitation is, number one, to differentiate and to demonstrate that this is a process that we're working with and that it can be rehabilitated. It is a rehabilitation emphasis, a regime of using lenses and prisms, and also therapy. But neurovisual processing rehabilitation is not therapy. NVPR is the working with assessing first the relationships of how the person uses their visual process in relationship to space, higher cognitive functions, posture, balance, and movement, and then to prescribe specific types of lenses and prisms and sectoral occlusion, which will affect the imbalances in the visual process. Following that, the neurovisual postural therapy is something that we've been developing, which works with the spatial visual process in conjunction with the base of support, proprioception, and the kinesthetic system, as well as the vestibular system, but primarily organizing it and grounding it with the proprioceptive or base of support. So this should become a little bit more clear as we get into it. So I'd like you to look at a video. So this young man was hit by a boat. He worked at a boatyard selling boats by day, went to school at night for engineering, sold a boat one day. Following day, he and his colleague went out to pick the boat up in a forklift. He was walking next to the boat when the hydraulics failed on the forklift and dumped the boat on his right shoulder, neck, and back. Didn't hit his head. Taken to the hospital, MRIs, CAT scans negative. Sent home. Following morning, tried to get out of bed, fell on the floor. Kept falling into the right side. A year and a half later, after experiencing this, took himself off the road. Was seen by a number of eye doctors. All told him there was no problem with his eyes and that he should get on with his life. Came in with his fiancée. She walked out for a moment and he blurted out to me, "I'm about to break my engagement." Saying that to me just meant to me that this guy was at the end of his line and that he was basically saying, you know, either pick up the ball and help me out here, or I'm not sure where I'm going in my life. So as therapists, as rehabilitation specialists, what did you just say? This is a workshop. Okay. So talk about it, what you saw from your professional discipline. There's no right or wrong answers here. You all know where I'm going with this. There is a visual component of it. I'd like you to talk about it and hear what it is from a PT, OT perspective, from other professionals that are here. What did you first of all observe? Yes.
His trunk is right side flexed.
Very good. Flexed into the right side with elongation of the opposite side. What else did you see?
He's neglecting his left side.
Neglecting the left side. Good. Anything else? Yes. Apprehension of his movement. Seemed to be very unsure of where the floor was. Kept reaching out with his left foot, tapping several times to see if it really was what he was seeing, or did it feel different? Good. Anything else? Scissor step. He did have a few scissor steps. And we've seen scissor steps before with patients that have various types of neurological difficulties. What does a scissor step usually indicate to you? Maybe an abnormal weight shift, so they're over on one side and they're bringing the other foot forward and they're so far over, it almost draws them over to that side. These are all good comments. I'm going to be offering to you the opportunity to see it from another perspective shortly, but I appreciate your getting involved to talk about the way in which you're looking at it from your professional disciplines. Was there another comment? No?
It could be a little focally bound, just in the sense that he's so internalizing here, and I'm kind of. She's taken your course.
Okay. Okay. I was about to say, wait a minute. You're absolutely correct. The term focal binding, focally bound, is a term that you're going to hear today. And there's two visual processes. So I'm jumping ahead a bit. So it's overusing one process and not enough of another. But you're right. This is exactly where it's going. Well, let's jump from the video. So I use this as a teaser. So I'm trying to get you thinking about the way you see things now. And let's apply some new ideas. Let's look at some patients. I even have other videos. Let's take a look at this young man again a little bit later. And we'll see if we can come up with a way of looking at this that brings us to an understanding of what the visual process truly is and whether or not we can incorporate the visual process into the very modes of rehabilitation that you're providing: physical, occupational therapy, nursing, neuropsychological rehabilitation. Any of these areas, you all work with vision. Every day when you're working with a patient in OT, PT, and speech, neuropsychology is no exception, you're primarily working through the process of the visual system in conjunction with other sensory motor systems. So in order to do this, we're going to have to create a dynamic understanding of vision as a process, not just as a sense, but as a process. And we tend to think of vision in terms of what we see, how clear we see. If you don't have a problem, you go into your eye doctor once a year, once every 3 years. He puts a chart up down the end of the room, asks you which is better, 1 or 2. You say 2. He says, here's your glasses, see you again. Doesn't work that way when you have a person with a neurological challenge. The primary interest from many professionals right now, because of this heightened awareness of traumatic brain injury, mild traumatic brain injury through concussion, is understanding the role of concussion and what we can do to try to solve the problems. But I can tell you, this is the tip of the iceberg. That once you open up this door, you're going to get flooded with patients. And you already know, as PTs and OTs, you have stroke patients, patients with Parkinson's, multiple sclerosis, Friedreich's ataxia, cerebral palsy, autism, and they all show neurological challenges with posture and balance. Correct? So I'd like to broaden the base of my discussion this afternoon to include any and all of these patients, because they need to be respected and included rather than excluded. So certainly we need to help those with concussion, traumatic brain injury, but Lyme patients are going to show similar things. Lyme disease patients and tick-borne diseases and a wide variety of other things. So keep an open mind so that we just don't focus in one area, and let's proceed forward. So if we're going to create this dynamic process, we have to start to define vision, and we have to recognize that vision is very much involved with movement, posture, balance. It sure is involved with our thinking, cognition, as well as our memory. And it's also involved in speech and language. Seems strange to say speech and language, but I mean, I have videos here. We can probably get to it today. We didn't have time this morning, of one man that had a concussion and Lyme disease, and he came in and he couldn't talk. Upon applying the prisms, he came in the next day talking. It was amazing to me too. So what am I saying? Am I saying let's prescribe prisms for every speech therapy patient? Nope. I haven't a clue as to what really happened with him, but I've seen it with other patients. I have a theory that it has to do with time and space relationships that happen in the vision process. And when you get to become focally bound, as you just mentioned, isolating on detail, it interferes with this relationship of how to organize anticipation, change in motor movement. Well, what does speech and language have to do with that? I'm moving my mouth, my tongue, my lips. My thinking, the words, are ahead of what's coming out of my mouth. If I become focally bound in the visual process, it's going to directly affect my thought process. If I become spatially bound and not be able to use the spatial process properly, the spatial process feeds all the motor cortex and the organization, even in the Broca and the speech language area, to allow the fluidity of the speech through oral motor to happen. When this jams up, you're going to have some experiences later on that I'll put you through. You're going to see what happens. I'm going to jump for a second and say, okay, let's broaden the space here, because it's not just as we see the quote neurological event, concussion, traumatic brain injury, cerebral palsy, aging. You know, it's like standing on the shore and the waves coming in, and pretty soon you're up to your ankles in sand. That's what aging does. Sometimes it's a slow process, diminutive process. Sometimes it happens more rapidly. Alzheimer's, Parkinson's, all have components of visual processing disorders. So now, what am I saying here? Am I saying I can cure Alzheimer's and Parkinson's? No. But you sure can affect quality of life and reduce risk of fall. Just like the way you look at those patients is the way we as optometrists and those ophthalmologists that have an understanding of this area need to approach it. We need to stop saying which is better, one or two, out the door, and we need to start listening to our patients and understanding what they're saying. So with aging, we can have common symptoms associated with aging. And frequently, these are vertigo, problems with dizziness, balance, eye strain, and many of them will have problems with light sensitivity. You know, before this field started, there was no field. And this morning I told a little story to the group about how I got involved in it. And I graduated from optometry school, got a fellowship over at Gazelle Institute of Child Development. Gazelle was a famous researcher and clinician, and he was the one that put together the cycles of development for the child. If you've never read any of his work, it's really fascinating. But he was also the first one that recognized vision was the mover of development. And the only firm predictor of a delay of development is blindness. So you take vision out of the development and you will be able to predict a delay in development. But so he realized vision was very important. He brought in my mentor, Dr. Richard Appel. And then so I was given this remarkable fellowship to study vision in development. So I saw many children and adults, some with neurological problems and physical disabilities, many without. And in so doing, I spent time listening to those patients as well as understanding the role of the psychologist in looking at the development of the child. We had developmental examiners who evaluated the children. There used to be a little screened-in booth that I would sit in next to the psychologist, and at one point, at time, we also had a physician, and we would sit there with the screen. The child couldn't see through because the lights were on the other side. And the developmental examiner would go through the copy forms test, the incomplete man test, memory tests, and then do Rorschach tests and a variety of different developmental tests. And it was fascinating to gain the understanding of it. Then we would all meet afterwards to discuss the child. And the psychologist finally said to me one day, he said, I gave my presentation of what I was picking up in the child in terms of how the child was processing. And Dr. Walker's turn came around and he said, I don't have to do it. We also looked at him as if to say, why not? And he said, well, Bill, he said, you just gave my entire understanding of the psychological development of this child. There is crossover between vision and psychology, but it's coming from a very interesting area. It's not coming from cognition directly. It's coming from an obscure relationship of the visual process with posture, movement, and balance. So when I graduated there, I went on and I was a member of American Foundation for the Blind as their national consultant in low vision. I was always interested in working with patients that had a vision impairment called low vision. And I enjoyed working with optical devices to take a person with legal blindness and enabling them to be able to read again or see their child's face or look across the room and watch television. In some cases, even designing spectacle-mounted telescopes and enabling visually impaired people to drive an automobile. I did a video on the California freeways where I was in the side seat. There was a videographer in the back seat and a visually impaired person with a pair of glasses with two telescopes sticking out so they could look beneath it and then through it. And it was fascinating. The drivers, we did several drivers, and they were picking up details and reading signs down the road far beyond what any of us could do with 20/20 acuity. And they were good drivers. So I decided I wanted to open up a not-for-profit low vision clinic in the state of Connecticut. I just wanted to do that as part of a service. I thought it would be good to work with children. I had a strong background with that, and I thought I could apply it to visually impaired children as well as to adults. So we got grants, we got optical equipment, electronic equipment to help them. We opened up the clinic. First day I went in, and patient after patient was stroke, Parkinson's, Alzheimer's, cerebral palsy, autism. At the end of the day, I walked out to my coordinator and I said, "What are you doing to me?" I said, "We're supposed to be seeing macular degeneration, glaucoma, maybe retinitis pigmentosa." She said, "Well, you should have thought of that before you opened up in an Easter Seal Rehabilitation Center," because that's all they had. So I would dread the day of going to this clinic that I just opened 2 times a week. So I did a literature search. It's a complete void of anything to do with vision and in relationship to the type of things these patients were describing. And what do you do with them? I was stuck. So I had to dig very deeply. And I kept thinking about what I had just learned in my fellowship and remaining on staff at Gazelle Institute, and how this visual process is learned. But it learns and it grows out of an action system. It just doesn't all of a sudden, the child just doesn't all of a sudden say, "Give me the New York Times." It doesn't work that way. They go through a developmental hierarchy to play with a ball, to roll over on their stomach, to move into flexion, to move into extension, to create trunk disassociation and head and neck disassociation and visual disassociation from balance, all for a specific reason, to organize higher levels of visual processing, to engage, to develop visual skills, to be able to track, converge, focus, make quick eye movements. These things are not innate. They come about through organized developmental sequence that occurs with the child's relationship to posture, movement, and balance, hopefully upright against gravity. So in some ways, I end up talking more like, I've been told, I talk more like a physical or an occupational therapist than I do as an optometrist. But I spent many years with PTs and OTs and have great respect for them and the profession of speech therapy. Christine Nelson, Dr. Christine Nelson was an occupational therapist, a PhD occupational therapist. And she got her NDT certification through working directly with Dr. and Mrs. Bobath. And she invited me to speak one day at her 8-week training program and certification for teachers and therapists in NDT. And I went down and spoke, gave my presentation for a few hours. And she said, "Would you like to see what we do?" I said, "Sure." She took me into the grand ballroom of a Hilton hotel in Little Rock, Arkansas, where she had rented out the entire Hilton Hotel for 8 weeks. I'd never seen anything like this. I walked into this ballroom, and there was nothing but bodies from one end to the other, all lying on mats. 2 therapists per child or adult, with instructors walking around. It was very well organized. I was completely impressed. Kind of intimidated by the experience. And as I was walking through, I saw this child, and I said, "That child has an exotropia." She said, "Which child?" I said, "That one over there." She looked at me, and she looked back to the child, and she got down low, and she walked over, and the therapists were working with the child. And she got down on her hands and knees, and she excused herself to work with the child and asked the therapists to move away. And she took the child in the most gentle touch. And she looked at the child's head and neck and postural organization. And this child had problems with head control and postural alignment. And she placed her hands at the occiput, the base of the cranium. And with the very lightest touch, whatever she did, I watched these 2 eyes line up. And then she let the child go, and she said, "Go ahead, continue." Well, I had never seen that before. They didn't teach that one in optometry school. I said, "Do you mind if I come down to visit you?" She said, "Not at all." I grabbed the next plane as soon as she went back to her office, which didn't happen to be in the United States. It was Cuernavaca, Mexico, where she had her clinic. And I just spent time just observing. And I went down again, just observing, because I'd never seen anything like it. So finally she asked me if I would work with her and see a few patients. And little by little, over 30 years, working with her, we began to piece together a relationship between vision and the postural relationships of development, and how the spatial visual process connects early on with posture and movement. And I have to credit her as well as her partner Raquel Muniz for giving me the understanding of posture and movement and the motor system. I've imparted to them the understanding of vision, and now Raquel and I do lectures all the time. So anyway, that's the interesting way in which I got involved in this. So I had to learn to listen to the patients in the clinics, and over time I began hearing the same thing over and over again. And as I began to hear that, I began to piece together an understanding from this relationship of understanding the child's visual process and development, and what I knew about lenses and prisms, and began to understand it in terms of some of the problems that we're going to discuss today. Anytime there's a vision impairment or visual processing dysfunction caused by a disease or a neurological event, it directly affects mobility. It'll affect reading, the ability to recognize things and places they are, as well as faces. It certainly interferes with driving, and it causes glare sensitivity. And it can also increase anxiety. We had a gentleman in earlier who came up to me after the first hour and a half, and he said he wanted to thank me for speaking all about who he was. I said, "I don't understand." He was a police officer in England and assaulted severely. And he said his life has never been the same. And he got very emotional, and he couldn't talk about it. So I looked at him, and I could see what was going on. He was actually having problems with alignment of the eyes. He had post-trauma vision syndrome. And I spent the whole morning, as I'm going to do with you, talking about him. So it can increase anxiety, loss of independence, decreased socialization, loss of employment, difficulty with personal hygiene, inability to follow medical as well as rehabilitative recommendations. And when these people lose their independence and their ability to organize themselves, they frequently lose the ability to care for a pet. And if they're living by themselves, that can affect the pet's health. So a neurovisual processing dysfunction affects posture, balance, something called spatial orientation, attention concentration, as well as the integration of the 2 eyes. And this posture, balance, and movement and spatial orientation is affected because there's a mismatch between vision, not as we know it in terms of sight, but with spatial organization and the sensory motor system. The leading cause of a neurological problem in the world, and most prevalent and increasing in incidence, is cerebrovascular accident. And that's for over the age of 65. And in our country, in the United States, Medicare has demonstrated that it's going to be one of the leading causes of putting tremendous economic pressure on the Medicare system because of the fact that we need to then have rehabilitation, and many of these patients become plateaued and don't go beyond certain points. Many of these patients have homonymous hemianopsias and spatial neglect. And anytime a person has a homonymous hemianopsia, a spatial neglect, or a postural problem related to gravity and balance, there is a visual spatial processing dysfunction that has been overlooked because we don't define vision in terms of balance and movement. The National Center for Health Statistics demonstrates that in the aging population, for those over 65, they'll have balance problems. And I think it's 1 person in 3 over the age of 65 will fall each year. There's a very high percentage of those individuals that hurt themselves and require medical attention, even traumatic brain injuries. In order to understand vision, we have to create and look at it in a dynamic way. Vision is misunderstood. There are lots of myths about vision. These myths are that vision and sight are the same thing. They're not. Sight is, can you see a detail at a certain distance, and what's your scope of field? But it doesn't tell you how you used it. So you can have 20/20 vision and normal scope of field and trip on the threshold walking out of this room. Visual relationships to a neurological event. To understand this, we have to develop an understanding of the visual process as a process, not just as a sense. Right now, vision is listed as one of the senses. Well, it's more than a sense. Did you know that 70% of all the sensory nerve fibers in your entire body come from the 2 eyes? Many of these fibers don't go to your seeing area of the brain. They match up in areas of the brain directly related to posture, balance, movement, spatial orientation, memory, higher cognitive function. They organize. If you don't have a processing system that's balanced, it's going to directly affect your perceptual abilities, whether it's a child who's in development or an adult following a traumatic brain injury. So transformations, perceptual constancy, figure-ground relationships are all going to be affected once the balance of the visual process is interfered with. Our goal in bringing optometry through Neuro Visual Processing Rehabilitation and those ophthalmologists that are trained in it to this group is to demonstrate that we have something that we can provide as part of the interprofessional community. Not to look at it in terms of the acuity model and the static model, but to work with you in understanding those dynamic relationships related to performance involving movement, posture, and balance. To accomplish this, we're going to have to do a paradigm shift in our thinking. We're going to have to create a new model of vision, one that's not a static model. When I was back in optometry school, we had lunchtime meetings with a professor in our senior year, graduating year. We all couldn't wait to get out of school, so we would see patients in the clinic, and then he would meet with us at lunchtime. And one day he said something that, you ever have somebody say something that you don't understand, but it becomes a profound statement that keeps ringing in your mind? He said something to all of us. He said, you're going to have to create your model of vision. We kind of looked at each other and we saw this plastic model of the eyeball up on the shelf, thinking, is that what he's talking about? A model of vision? What do you mean by a model of vision? We learned that there's nerves, there's muscles, light goes in, back up to the brain. What else is there to know? Little did we know. We're going to need to understand the relationship of posture and movement. And in order to create this model and understand that we can influence it, we're going to have to apply the principles of movement and posture, as well as to understand that we can influence it through prescribed lenses, and prisms. I came upon some research a number of years ago by a doctor by the name of Colwyn Trevarthen, who is a fascinating person in that he was not working with humans, he was working with primates, chimpanzees. He started off at the University of Oxford, England. He came to Harvard University in Boston. And he basically came up with an idea from looking at these chimpanzees that there were two visual processing systems. Kind of saw it this way, and I'm going to do a very poor job. I'm glad he's not around to hear this analogy, but it's kind of like Trevarthen walked into the laboratory one morning where the chimpanzees were in a main cage. And he opened the door, and the chimpanzees were scurrying around. They heard the sound. They looked over at him, saw him carrying something yellow in his hand. He started to move to approach the cage. The chimpanzees released from looking at the yellow object, scurried across the cage. Trevarthen walked up to the cage holding out the yellow object. The chimpanzees looked at the yellow object, guided hands to reach for the yellow object, peeled it, ate the banana, threw away the peel, and scurried across the cage again. A simple way of saying there are two visual processing systems, not one. He described very eloquently one called a focal process, one that we use for detailed discrimination, identification, attention, concentration. I have added to this, it's oriented to the present. It's always now. He added that the focal process is a conscious process. I've added to his list that it reacts to stimulus. It's reactive. So doesn't that say everything there is to know about vision? No. Those chimpanzees had to release from the target they were looking at and organize their vision in terms of not looking at a detail, but maintaining organization of space, posture and balance, somewhat upright to gravity, and negotiate their way spatially to meet Trevarthen at a particular point in the cage by using a part of the visual system that is oriented towards spatial orientation, and it's for posture, balance, and movement. I've added to this, it's never interested in now, it's always interested in the future. It anticipates change. Trevarthen said that it is preconscious, and I've added to it, it's not reactive, it's proactive. Boy, that's a tough one to grasp. How can something be proactive and anticipate change? Well, it's happening before the event. We'll talk about that again in a moment, but of these two systems, the focal process, when you're looking at something like, what is this? It's a pen, pointer, okay? You recognize it. By the time this image got to the seeing part of your brain, the other system was over and done with what it had to do. Before you could look at this as a pointer pen, the other part of the visual system locked onto it as a vertical line, and through another part of the retinal cell geniculate system, instead of sending the image up to the higher seeing part of the brain, it fired it down to the midbrain. So what happens in the midbrain? Anybody know? Well, the midbrain's been called a lot of things, way station, a sensory motor organizer. Well, the visual process is right there with it. It's there to send spatial information about vertical and horizontal lines in our peripheral vision that I'm not paying attention to, and you're not now. But as I point this out to you, aren't there seats in front of you with horizontal lines? Aren't there vertical dimensions to the corners of this room? So now they're focally in nature for you, so you're seeing them. Before, you didn't pay attention to that. So your visual process is picking up all these boundaries and using these boundaries to send down to midbrain, and the spinotectal tract is bringing up all this sensory motor information to the brainstem, which feeds it forward to the superior colliculus in the midbrain to match up spatial information from proprioception, kinesthesia, tactile, to come up and match up with what the visual spatial process is saying, you're upright against gravity or you're in trouble, something's about to happen. And then the vestibular process kicking in and saying, whoa, hold on here, something is way out of alignment. Mismatch of information is what we're going to be talking about today. For the child in development, it's all about gaining organization and support from one system to the other. So of these two systems here, optometry and ophthalmology have primarily focused, I'm using that not as a pun, on the focal visual process. We look to see how clear we can make a person's eyes. Do they have open field? Eyes are healthy, no pathology, you're good. But now, one moment in time, and you get a concussion, a whiplash, you're born with a congenital neurological problem, you end up with an aging neurological problem like Parkinson's disease. One moment in time, the processing system that we never think in, that is really more a proprioceptive part of our visual system than a sensory, well, proprioception is a sense. It's more part of the motor system than it is part of the sensory regard system in terms of cognition. You can't think in the spatial process. Slowly or in one instant, when this system is involved, this is where you're going to have the problem. If all you do is look at a person's eyes from here up, you're missing the base of the iceberg. The ambient visual process integrates with kinesthesia, proprioception, and vestibular. It feed-forwards to 99% of the brain before the image of this, identified as a pointer, can reach the occipital cortex. And it does so that the spatial process sets the platform base up before the detail is applied. Like saying, make sure you have the table set up before you go to put the dishes down. Or at least make sure we have 4 strong legs on the table. Once it gets to cortex, there are multiple areas that match spatial information and create brain mapping. Frontal lobe, parietal lobe, occipital lobe. And they all have a different purpose in creating a map. Some for intention, some for initiating movement in terms of space, some in terms of applying the detail to a spatial context, but without the base of support, all these systems collapse. And the base of support is this link between the spatial visual process and particularly the proprioceptive base of support. And I don't want to avoid the conversation of discussing the vestibular system because it is very important. Somebody asked a great question at the end of the presentation this morning because I wasn't really talking about vestibular, but vestibular has to ground in proprioception too. And it particularly grounds into the proprioceptive system in the cervical area. So as the child's developing, the child develops the ability to disassociate trunk on body with rotational movements. And if you watch the child, the head is still connected to the trunk. And then as the child gets a little bit older, the child learns how to disassociate head on trunk on body, making a rotation, and create disassociation between the focal process, which we saw before, and the spatial process, so the child can look, reach, step, weight bear, and not lose postural orientation. Initially, when the child does it, it's like watching a slow tower fall over. But as the child gains organization of that, the child then learns how to use the spatial process, grounding the vestibular system into visual spatial, and the proprioceptive base of support, as well as proprioception in the cervical area. Have you heard of the oculo-cervical-vestibular triad? Is that a term that you're familiar with? Okay. Basically came from the work of Dr. Christine Nelson and Dr. Josephine Moore, and I think there was one other person, but I don't remember who it was. And if you've never seen Dr. Josephine Moore's lecture on vision and anatomy, go to cliniciansview.com, and it's one of the most amazing anatomy lectures I've ever seen. She became a PhD, and she taught the medical students anatomy at University of Iowa till she retired a number of years ago. Fortunately, they videotaped that one lecture. So the ambient process is pre-conscious. Before you can think, the ambient process already was involved, setting the platform base up for you to operate with. It's feed forward, and then it receives feedback from the cortex. It's constantly readjusting and adapting. It's where plasticity is in the visual process. Neuroplasticity occurs in the spatial visual process so long as it's grounded in the proprioceptive base of support. If that's compromised, the focal process takes over. And the focal process is like concrete. There is literally no adaptation in the focal process. So think of a balloon or think of a concrete ball. I'd much rather play with a balloon than with a concrete ball. To operate a visual system that becomes focally bound, as you pointed the term out, you become very jammed and inability to adapt to time and space. So it's all about balance with these two systems. The two systems have to maintain a balance and a relationship between them. Once this balance is compromised, that's when we have the problem. So the focal and the ambient process are very much like this boat sitting out in a harbor, and this is not Nova Scotia, this is Connecticut, near where I live. And these are the Thimble Islands. There's 115 little islands like this, just east of New Haven. And the legend is that one of the famous pirates, I think it was Captain Cook, used to hang out here, and he buried his gold up there somewhere. So if anybody wants to go down and find it, nobody's ever found his stash. But anyway, as I was saying, the focal process is much like this boat sitting out in the harbor. You see it. It's what we see. But what you don't see is this rope that goes down to the anchor. It grounds that boat. If you cut the rope, the next tide is going to come in, and the boat's going to drift away. As long as you're grounding the boat, it'll be stable. That's exactly the way the spatial visual process develops from the earliest moments of life as well as before life is in the fetal infant. The spatial visual process is still evolving. It's just a graphic to demonstrate that we have two eyeballs, the optic nerves, the chiasm, nasal fibers cross, temporal fibers go straight back. Lateral geniculate, there's a synapse. The spatial visual processing system is primarily from the peripheral retina. At least 20 to 30% of these fibers send axons down to the midbrain through the superior brachium. Other fibers are delivered back through the optic radiation to the seeing part of the brain. And then there's more spatial information that's dropped back down, as well as the spinal tectal tract, bringing up spatial information to match with vision, to feed forward to 99% of the cortex, as well as to set the spatial format in the occipital cortex back up through the optic radiations. All this is there in the literature. But optometry and ophthalmology never paid any attention to Colwyn Trevarthen, as well as to all the famous neurovisual scientists of his day, 50s, 60s, 70s, 80s, and into the 90s, who constantly talked about the bimodal visual process. I went over to Oxford, England. I didn't get into the stacks. It's a funny story where I tried to get into the stacks in the University of Oxford. They wouldn't let me do it. They pulled up a stack. I had 3 stacks. The head librarian said, go look through them. I thought it was an undaunting task. The first one I picked up, thumbed it open, there was the paper I was looking for. And it was in a symposium of all the famous researchers of the day. They were all talking about 2 modes of visual processing. Later in the 1980s, they found 2 pathways. We're going to show it in a few minutes. One is called the parvocellular system for focal processing, and the other is called the magnocellular system for spatial processing. So these researchers were understanding this before they even knew about the neurological pathways. So where I'm leading you to here is that we have two pathways, and we have a spatial visual process that works very differently than the focal process. And you know, we've heard so many, every time I pick up a book about the eyes, whether it's in optometry, ophthalmology, psychology, education, OT, PT, wherever it is, it always talks about the eyeballs like a camera, light going into the eyeball, transferred back up, image, and then the brain does the rest in terms of psychology, other areas, perform movement. It doesn't work that way. And that's because we've never asked the right questions. As the field of optometry and ophthalmology developed a clinical model, and what caused me to develop the research was because I started seeing things in a different way, and I started treating patients, and I was getting such amazing results. I started talking to other doctors, and that's how the Neuro Optometric Rehabilitation Association was established in the United States. I was coming home every day at the end of work, sitting down at the dinner table, and I'd be saying to my wife, "You're not going to believe what I saw today and what happened." And this was going on night after night, month after month, year after year. And she very delicately one night said to me, she said, "Bill," she said, "is there anybody else you talked to about this?" I said, "No, dear, you're the only one." She said, "Is there anybody else out there that you can talk to about it?" So I said, "Well, yeah, there's John Thomas, he's in Arizona, Vince Veach, he's in New Jersey, and then named a few people that I heard were doing something, but I've never really spoke to them." She said, "Why don't you call them up and invite them to meet you somewhere?" I said, "Great idea." So I wrote everybody a letter. I said, "This is what I'm doing. I heard you're doing this." I said, "I'm going to be at the Knickerbocker Hotel in Chicago, January 10th, such and such a year." I think it was 1989. And I said, "Join me." I said, "I just want to talk about this with somebody else. My wife has suggested it." And we met for a full day. It was fascinating. We took notes on it. I have the original notes. And it was so incredible because we found we had a lot of overlap. We also had directions we were going in different ways. We learned from each other. We decided to meet again. Next month we met again, same hotel, and again. And then we started getting letters. I think this was before the days of email. We got letters and phone calls from not just optometrists, but from occupational physical therapists, from psychologists, from physicians, saying, "We'd like to come and join your study group." We said, "Nothing doing. This is a private study group." It kept getting more and more emphatic. "We want to come to the meeting." And we realized we had to do something. So that's how NORA was established, the Neuro Optometric Rehab Association. And when we established it, we were getting a lot of pressure to make it an optometric organization and to keep it optometric and just among the optometrists. And we looked at each other and we said, how are you going to keep a rehab model just for optometrists if we don't have OTs, PTs, and speech therapists as members of this organization, as well as physicians and psychologists? What are we going to do? Sit in a room like we started out, just talking about, wow, isn't this cool? So we created it as a multidisciplinary model. I can't tell you the flack we got from the American Optometric Association and the American Academy of Optometry. And we're still getting it. But to this date, it is the only optometric organization that has maintained an interprofessional nature, and we're proud of it. So anyway, I somehow got off the track, didn't I? Coming back to understanding this relationship of the visual process. Anyway, we met, we started the organization, and what we began to think about is that if you're not asking the right question, you're not going to get the right answer. So we kept asking ourselves the question, well, why are we finding what we're seeing? Why are we seeing the changes? And why hasn't optometry and ophthalmology seen the change before? And I brought out to the group that I began to think back to my days in psychology. when I was a psychology undergraduate and I was studying learning theories. Again, one of those things, why does that stand out in your mind? I don't know. But those learning theories weren't important to me then, but I remembered them. And the stimulus response learning theory is certainly proven by Pavlov, B.F. Skinner, and it's a little black box experiment. Put a piece of meat in front of a dog's nose and they'll salivate. Or you can create operant conditioning and teach a mouse to press down a particular lever through positive reinforcement. Stimulus response. But that's not the way I lead my day. I don't wait for everything to happen. And that's not how I saw each one of you walk into this room. You weren't waiting for an event to happen. You actually carried out movement, and you were using your visual process as if there was a response before the stimulus. And if you go back to the early developmental models in psychology of how learning theories, you'll find that stimulus response was only one model. Why did it get applied to optometry and ophthalmology? I guess because it was easy. Easier to say which is better, one or two. But kids don't learn by stimulus response, or they shouldn't. They learn by matching spatial relationships of the visual process with the sensory motor system. They create this anticipation for learning and movement, not reactive. This spatial orientation gives way then to understanding that there is another mode or another model that we can apply to rehabilitation. And you're doing it every day with all your therapies, particularly in PT and OT, because you're working with movement and creating the anticipation of movement through weight shift, weight bearing, postural alignment, but you're also using the visual spatial process, engaging that through the proprioceptive base of support to help stabilize the vestibular system. I'm going to give you an example. I didn't give this to the group this morning, but I think it's timely. When I give you this, you're going to create a visual image in your mind that I don't think it will ever leave you. And you've probably all seen that great movie by George Lucas called Star Wars. Well, he created the perfect analogy of the focal and the ambient visual process. Think of the two droids. Now, first series, not the new one. The first series had C-3PO, okay? And why he walked with an English accent, I don't know. You'll have to ask George Lucas that, but it's not significant to me. And this other little droid, which was beeps, boops, rolled around, seemed to switch, always in anticipation of the problem that could occur. Yet, when an event occurred to Starfleet Command, C-3PO was suddenly in a reactionary mode, became even more ataxic, had a limbic system that fired through the roof, became very emotional, and would drift off, mumbling to himself, not knowing where or what he was doing. Yet the droid, somehow, R2-D2, could always anticipate what to do and how to respond to the attack on the Starfleet Command. We are all C-3PO if we do not have the ambient visual process. The moment we take away the ambient visual process, remove R2-D2, excuse my analogy, we lose the ability to adapt to our environment. We become rigid in our movements. We become rigid in our thinking. Memory will be affected. Everything will collapse.
Can I ask a question?
You certainly may.
I was treating a young child that was hypotonic, and her ligaments were
Did you say hypoclonic?
hypotonic,
Oh, hypotonic.
and diagnosis hypotonic, but I'm saying, but these are loose, rattly ligaments. There's no turgor in these ligaments. You're not getting proprioception. I think somebody needs to look at loose ligaments, Evers-Daniels sort of thing. No, she has hypotonia. So ligaments and ligament quality probably plays into this because it's all about proprioception.
We're going to talk about postural tone in a little while, but since you brought it up, absolutely. Absolutely. Low tone, high tone, abnormal postural tone, localized in different areas. you're going to see some videos, and I'm going to show you the changes in postural tone. It's going to change your way of thinking. So allow me to be broad, and I'm actually, we don't have that much time, so I'm trying to be focused. I'm using my words as carefully as I can to bring us to a point of understanding the visual relationship. But you're absolutely correct. You can broaden the base here and say, you know, it's not just muscles and joints, it's the ligaments, it's the relationship of the fascia to the muscles and the joints. All this is combined, all right? Is that helping you? Leading open the...
You understand most people may have problems that we haven't recognized.
They do, and that's why I'm broadening the base of our discussion today from just TBI, concussion, to say, yes, all these patients, any patient that has a neurological problem is going to have a visual processing dysfunction. 70% of all the sensory nerves in your entire body come from the two eyes. They don't all go to what is this, they go to where is this. Many of them start out there. The child is first born not with a focal process. The child is first born with a where is it system that is spatially oriented to give priority of organization toward motor system, postural alignment, upright against gravity, and to ground the vestibular system. The focal process occurs secondary to the ambient visual process. Okay? The ambient and the focal process cannot serve separately. If you have one or the other, you're going to have a dysfunctional system. The midbrain and the brainstem are critical for this relationship of the postural base of support in relationship to spatial orientation. The cortices are critical for consciousness and for providing feedback to the midbrain and the brainstem and the thalamus to give reorganization of the information that's being sent forward. Let's look at the neocortex for a second. Here's the mouse, the monkey. Look at all the convolutions in the human cortex. Each convolution means that we have more area of the neocortex than the mouse. So that's why we're smarter than the mouse. But it's more than that. If you look at where all the action is, it's about 2.5 millimeters thick in the cortex. And there are 6 layers in the majority of the cortex, 3 of which are oriented toward interrelationships of transfer of information from one of the cortices to the other. 6 of the layers, 3. The other 3 layers are oriented toward input and output from midbrain, thalamus, and brainstem. So that means half of the information that's coming into the neocortex is not cognitive. It has to do with other things related to space, posture, and movement. When you get to the occipital cortex, something interesting happens. Here, an additional 3 layers are added. Why? Now a total of 6 layers are oriented strictly to all the information coming in from thalamus, midbrain, and brainstem. Only 3 left for intercortical interchange. It didn't change. But what did change here is that the hierarchy is primarily oriented in development toward the spatial organization first, and that it never goes away. I've read research and books by famous researchers saying that this whole system goes by the wayside and the parietal lobe and the temporal lobe and the frontal lobe take over. It's not the way it works. If you have a person that is having problems with tracking following a concussion, if you have them hold the target so that they get tactile kinesthetic input and have them track the object, you will see a dramatic change in their ability to fixate and track the object and anticipate change. It's not coming from a cognitive base. It's not coming from the parietal lobe and the frontal lobe. That's coming from midbrain and all the information that's coming in from the spinotectal tract. Let's talk briefly about the brain. The occipital cortex are marvelous and exquisite brain center, organized through evolution as well as through development to organize the visual image and to create spatial mapping. It receives input from many different areas of the brain, particularly superior colliculus. the frontal eye lobes, the thalamus, the brainstem, and it gives output to many of the same areas. So this interchange and matching of information is critical. It's primary for the organization of visual processing related to attention and concentration. No doubt about it. The temporal lobe matches visual information with auditory. It's very much involved with the frontal eye fields, for a spatial context. It's getting input from many of the areas the occipital cortex is, as well as providing output. It has a lot to do with the temporal relationships coming through the auditory process and matching up with temporal spatial visual processing. The midbrain, overlooked in terms of its relationship to higher sensory processes of the visual system, but there's a little bump in the midbrain called the superior colliculus. And this is where all the spatial information from the peripheral retina is being sent by synapsed axons down to the level of midbrain to match up with that spatial context coming up from the spinal tectal tract to the brainstem, and then it jumps over to the midbrain. It functions for early spatial contact and fusion. Fusion is the ability to integrate the two eyes together. Take the images from the right and left eye and integrate them together. Well, if you have a problem early on in life, such as cerebral palsy, and the child starts to try to come upright against gravity, well, as therapists, you know that the spasticity does not occur in a child with cerebral palsy until the moment the child comes up against gravity. And it's only in a gravity-based environment does the child then have the problems with spasticity. If we were not in a gravity-based environment, children probably wouldn't have the problems. They'd still have other problems. I'm sure there would be some there. But gravity is the component which leads to the spasticity in cerebral palsy. So if you have this child that is also developing binocularity about the same time the child is now starting to do writing reflex and movement upright against gravity, that's when the strabismus occurs with these children. The other interesting research is to look at the research by Neighbor and Sieber. I think it was done back in the 80s, where they took mock monkeys and they did radiotactic lesions of the superior colliculus. And when they did the radiotactic lesions and sewed the monkeys back up and the monkeys recovered, they immediately saw that the monkeys had strabismus, exotropia. So this spatial information is critical for feed-forwarding to binocular coordination cells, which literally glue the images together before the image hits the occipital cortex to say that's a pen. The brainstem providing the proprioceptive field for sensory organization spatially. It's very involved in the early reflex patterns of the child, and of course those reflex patterns are critical in the development. But those reflex patterns are supposed to get integrated. And those reflex patterns are supposed to remain integrated. How do they get integrated? They become integrated because the ambient visual process stabilizing with the fascia, the ligaments, the proprioceptive base of support, with stabilization of the vestibular system, then takes on higher organization of sensory motor function to enable the reflex to remain integrated. When it pops up later in life, it's because something came out of balance. The midbrain is receiving information, as we said, from spinal tectal tract, controlling the autonomic functions, but also getting output to the superior colliculus and the frontal eye fields. The superior colliculus, there happens to be a bump about 0.5 millimeter or 2 millimeters away from the superior colliculus called the inferior colliculus. And the inferior colliculus receives information from the auditory system. Well, guess what kind of information? Not information about, I hear your voice. It's about, where is your voice? Where is that echo that I hear from the microphone? It's picking up spatial information, and there's fibers that go from the inferior colliculus, vice versa, to the superior colliculus. And both feed forward to the cortex to pre-organize spatial information, not just spatially now, but in a temporal spatial mode. Because it's not just about seeing where the glass is. It's about knowing what it's going to take in time to get to the glass. So we don't come in too fast, too slow. It's when to brake your car, when to accelerate, when to brake going around a curve, when to accelerate going out of a curve. Spatial information, it's temporal in the context of knowing how to organize the spatial information. I had a very fascinating conversation last night with Dr. Mandelman's husband, who also happens to have a hobby of as a race car driver. And it was fascinating listening to him talk about how he deals with space, traveling 180, 190 miles an hour, dealing with hairpin curves, knowing where he is in relationship to a car that may be inches away, and knowing what's going to happen at any one moment with his vehicle. Extraordinary. I mean, you can't explain that and put it into the definition and context of what I'm just trying to explain to you this morning. You know, there's some people that just have an extraordinary gift. The parietal lobe is matching auditory information with tactile information. The parietal lobe is a spatial mapper, but it's taking information from the superior colliculus as well as the frontal eye fields and the supplementary eye fields in the frontal lobe. And it's taking this information and it's creating spatial context for execution of movement. Whereas when we get to the frontal lobe, you're going to see this part of the visual system relates more to the spatial mapping and organization to create the intention of what we want to do. So the ganglion cells that come from the two eyes are, we talked about the magnocellular system, which is a spatial cell. It's a nerve fiber that comes back. And the magnocellular system is spatial, and it's coming primarily from the peripheral part of the eyes. And much of that information is being dropped down to midbrain, and it's also very rapid. The parvocellular system is like taking the local train down to Halifax from somewhere else, wherever you might get a train from. I was about to say New Haven to New York, but didn't have much context up here. And it's parvocellular in its detail. So it's the local or the express train. One travels very quickly. There's a third system called the coniocellular system, which seems to be operating like a gatekeeper. And it seems to be in normal development that it's a learned system to be used for a chemical, electrical gatekeeper to allow spatial information to pass through before detail information. It's kind of like being in a train, two trains coming down the track, and somebody throws up a signal to slow one train down to allow one train to pass through, then to allow the other train to move behind it. That's pretty much the way this system operates. And it goes all the way, the information drops down to the midbrain, and much of this information is then organized for spatial context, which then gives organization for our visual skills. So where does the ability to track, do a quick eye movement, converge the eyes, focus the eyes, where does it come from? Anybody here work with kids? All adults? Oh, that's interesting. Well, there isn't one portion of our visual system that does not develop as an organizational skill that doesn't come from the child's ability to learn with motor movement. And the moment you take motor movement away from the developing child, you are directly going to interfere with the developmental sequence of developing visual skills. So if you have an adult that has problems with tracking and quick eye movements and convergence and hasn't had any other type of neurological problems, and this person has been this way their whole life, then this person had a problem early back in development, And now it raises question, was there some type of a head injury early on in development that may have caused it? We'll talk about that more in a few minutes. But horizontal movements, quick eye movements from one point to the other, come from the midbrain. And it's the spatial context there, which organizes the quick eye movement. So let's try a little example. Hold 2 fingers up. Now, you know now there's 2 visual processing systems, right? So I want you to look at your left finger. Now I want you to quickly move your eyes to the right finger. What was the first thing you had to do? Now, I'd have to say you're all focally bound right now. You're all stuck on one finger, okay? But what was the first thing you had to do? Before you could think about it, you didn't think about moving your eyes. You did not. Look at my 2 fingers. Look at the right one, my right. Shift to the other one. What was the first thing you had to do? Before you did that? Well, knowing where it was, that may be the first thing, but not in the cognitive sense. You developed that in terms of a spatial map. Kinesthetically, you felt your arm. That information came up from the spinotectal tract. The superior colliculus was giving information about a vertical line over here, even though you were looking here. So it gave spatial orientation to that point in space. It sent information up to the frontal eye fields and the supplementary eye fields, which then mapped out the position sense of the target in space and created another relay over to occipital cortex as well as to parietal cortex, which then allowed parietal cortex to allow the occipital cortex to then send information to the extraocular muscles to make a quick eye movement. But what did you have to do before you did it? You had to what? Anticipate the movement, and before that you had to release the point of fixation. And when I told you to do that shift and I asked you the question, you guys were all stuck in one point. You were thinking, but you were still looking here, not up at me. Jammed the visual process because the cognitive system took over with the focal visual process, and you were stuck in time and place. The focal process brings you to the now. The ambient process must release from the fixation and enable the shift to occur through multiple mapping centers in the brain. One saccadic fixation combines about 13 to 15 centers of the brain. Every moment of the day, a saccadic fixation is a snapshot. Think about this. You don't spend much of your day in a moving environment. Your brain creates the awareness of movement. You spend your day creating snapshots. And each snapshot is linked into the next as if it's one context. And then your brain develops relationships in the peripheral visual system, like watching somebody's hand move from one place to another. Even though you are involved in saccadic fixations, it all looks like continuous movement. You don't see that. Your brain fills it in with something called visual closure. It's an amazing process. You don't see me. You see lines, shapes, and shadows, and you have pattern receptors in the brain which are picking up all these different lines and shapes and shadows back into binocular coordination cells, and there's a visual closure which establishes your experience about what I look like now, and what I look like now, I'm still the same person, a transformation. Dynamic, we don't think about it, it all happens preconsciously. Are you with me so far? Any questions? Okay. So the superior colliculus is pretty important for saccades. The vertical saccades are happening at brainstem. So now after a concussion, I do saccades on all my patients, and I just did research where the research was we did saccades slowly, and then we had another temporal sequence of saccades, and we measured in the experimental group saccadic fixations compared to a control group, concussion versus non-concussion. And we found out that we can screen concussion by measuring saccades temporally. And the saccades break down very, very quickly when you're looking at temporal relationship of saccades. So we're about to publish that paper, and hopefully we've developed an instrument that's a vision screening instrument for concussion, and that's one part of it. So the superior colliculus is for, I think I had it backwards. Yeah, I did. I said I had it backwards before. Superior colliculus is for vertical saccades. Brainstem is for horizontal saccades, but they're very much involved in this spatial mapping for this. Now the superior colliculus is involved in something that you as OTs and PTs know, and this is the relationship of head on body. And the brainstem is very much involved with trunk on body. So when we watch a child in development, we see the child tries to come up right to gravity, but they're rigid. And if there's any interest of the child to try to look like this, they immediately topple over because they haven't gained disassociation of trunk on body to make the rotation at a certain stage. And then once they do that, they then have to disassociate head on trunk or head on body responses to enable the child to turn the head. And when this occurs, they also have to be able to disassociate the focal process from the spatial process to enable the spatial process to reinforce postural alignment upright against gravity so that they can create a weight shift with elongation of one side of the body and compression of the other to reach over and pick up the toy and then come back to center. Beautiful to watch. I have a young granddaughter that I've been having a good time watching in her 7th, going on 8th month, going through these processes of learning to use the visual system in this manner. Well, everything about the visual process comes from development. What we're doing is we're realizing and creating a concept of the visual system that's a complex sensory motor response facilitated by the eyes and the extraocular motor system, but involving and emanating from an entire action system. So if vision is an act, it becomes an act, but first as a process. In order to create the act of vision, we have to organize the process. The postural relationships of vision are linked through physiology, development, and function. I like to look at this relationship of the head writing response as a critical phase in development for the child, because before that, the child's really in a lot of flexion, and flexion brings what with the eyes? Gaze downward. And when you gaze downward, you're usually looking up close. And what else are you going to do with the eyes when you look up close? Converge and accommodate. So flexion brings the development of the skill for convergence and accommodation and introduction. But the writing reflex, put the child on the belly, head comes down into the mat. The writing reflex stops the child from suffocating because the pressure builds up and the child immediately lifts the head away from the mat as a survival instinct. But what happens? The child moves into extension. And when the child moves into extension, what happens to the eyes? They diverge. And convergence, which is focalization, immediately turns into divergence, an expansive spatial world matched up with vestibular proprioceptive relationships to postural orientation to the vertical horizontal planes in the child's world. The quality of the posture determines the quality of function. Was it Sherrington that said, help me out, you probably remember this better than I do. I think he said something like the quality of a movement is only as good as its initiating position. Isn't it something like that? I thought it was well stated. And it made me think of, what would a baseball player on the Twins, how would he throw a 95-mile-an-hour fastball if he was told to throw the fastball from a seated position? You don't see that. You know, how does a soccer player, a world-class soccer player, do such an amazing job? Well, if they're going to be able to do that, they have to be able to be light on their feet, weight shift, and be able to organize that adaptability and facilitate movement so that they can do lightning fast movements, changing in direction. Hockey players, no exception to that. Our world-class athletes have an exceptional ability to use the visual system spatially and temporally in a way perhaps that you and I don't. So functional postures are maintained automatically. And we do this because if the functional posture is an automatic nature, such as the spatial process, then we don't have to think about it. And then we don't create fear of falling from being upright. We're allowing our higher visual system to occupy the nature that it was designed to. Attention, concentration, curiosity, thinking, cognition, memory, all those different facets. Somewhere around 7 years of age, that postural control becomes automatic, and it allows the visual system to create a dominance for conscious attention while still maintaining the organization of support from the spatial visual process. And it indicates a complete integration of the visual process in relationship to the somatosensory vestibular processes. But when there's a dysfunction and an imbalance posturally, it's going to directly affect spatial mapping. And when this happens, you're going to have a change in abnormal, or you're going to have a change in postural tone. It can be high, it can be low, it can be mixed, and it can vary. So the fluency and the balance required between the ambient and the focal visual process is critically based in the motor system. And we cannot have this balance unless we have an active involvement of the child in organizing it from a motor base of support. So looking at these two children, the writing reflex, and look at this child. Obviously the reflex is not there. You can see the difference in the TNR and the ATNR. Obviously changes in motor tone. Oops. Oh, this kid. I mean, this kid is really moving forward with, look at the curvature. And look at the flexion and the convergence that this child has, obviously with accommodation, same thing here. And here this child is now opening up to space, very much ready for this. Here the child on all fours, going into feet to hands, is able to create relationships with distance fixation to near saccades and focalization and convergence. And look at the extension posture and the convergence relationship. Look at the curvature and the extension, the capital, the capital movement forward with the chin, and here the chin down back into flexion. This is where the visual skills come from. I have more of these for you this afternoon than we did this morning. But look at these, the disorganized neuromotor state with these children and the perplexed state of the visual system with these children. Problems with postural organization, even on the stomach, disorganization of the ability to organize upright in all fours, problems with the writing reflex and inability to initiate change. And these pictures were all taken and shared with me by Dr. Nelson. So in conclusion, at this early stage of our portion of our process, when the visual system has processing dysfunction, it leads to compensatory body movements and malalignment, causes excessive use of energy. It'll definitely affect postural tone, and it also deteriorates the quality of the performance of the visual sensory motor system. Are there some questions about what we've spoken about so far? Okay, so we're going to now move into some of the syndromes, and I thought maybe this would be a good time to take a break. So I'd like to talk with you about dysfunction of the visual process. I've called it post-trauma vision syndrome with my colleagues. This research, if anybody's interested, was published in Brain Injury. If you want to read the research, you can just go to my website, which is padulainstitute.com. And there's a section in there on research papers, and my research papers are in there. But we'll talk about it a little bit. And I was working with Stephanie Argyris, who's a physician, head of traumatic brain injury at a hospital in New Jersey. And I was beginning to see these patients. You know, I was at that clinic I mentioned that I had started, and seeing these patients and hearing the same things over and over and over again from patient to patient. They weren't talking about, seeing more clearly. They were talking about strange things like seeing words move on a page or things move on the floor, having problems with their orientation in space, walk into a grocery store, can't find a bottle of ketchup, emotionally get upset by the fact that there was movement in the periphery. They'd get disorganized by this, light sensitivity, pain, headaches, discomfort in the neck, shoulders, all these strange type of things. You know, it's one thing to hear it from one patient, but when you hear it from 25, 50 patients, you start to think, why are they all saying the same thing? Nothing in optometry and ophthalmology program of education taught me anything about that. And I used to approach everything thinking about it in terms of, this person's got a convergence problem. Let's do vision therapy, and we'll do convergence training, and we'll do fusion training. And I would do that, and I would get reports like, "Doctor, why are you doing this to me? It hurts. It's painful." And I'd say, "Well, you want to get better, don't you?" "Well, yeah, but isn't there another way to get this better?" "Well, you have to work hard at it." But I would notice that the more I would work with these patients, the worse they would get. And the smarter the patient was, the more they wouldn't come back to me. They would disappear. And I was thinking, what's wrong? Why didn't that patient come back? Well, it's because I was thinking of this the wrong way. I was thinking about it in terms of convergence. You must work to work the muscles, converge, fuse, create pencil push-ups, do 250 pencil push-ups a day, and you'll solve the problem. It's only going to create more problem. Because if they have a compromised spatial visual process and you work the focal visual process, it's like saying put more wood on the fire. You're only going to inflame the whole process more. So we did visual evoked potentials, brainwave studies of the visual system, and we found some interesting things with the brainwaves. We used an instrument that looked like this. We used a checkerboard pattern that constantly reversed black to white. And I'm not going to go through the whole study, so I'm going to go right to what we did. We tested 10 subjects in an experimental group, 10 in a control group, and we looked at their visual acuity monocularly as well as binocularly. We then did tracking, found that the experimental group had problems tracking, control group didn't. We looked at convergence. We found out that the experimental group had problems converging. All head injured patients. The control group weren't head injured. They didn't have any problems with it. We looked at focusing. Same thing happened. Experimental group had difficulty with it. Control group did not. And we found that the reduced monocular neurovisual acuity, difficulty with pursuits and saccades, problems with accommodation, convergence, insufficiency. We found increased nearsightedness with the patients, even though a number of the patients were not nearsighted prior to the injury. And an increased exophoria, strong tendency for the eyes to deviate outward, were all results of our study. In the control group, we didn't find any of this. The normal visual acuity, the ability to converge, diverge, saccades, pursue tracking, all were within normal ranges. And they weren't all exophoric. Some were esophoric, some were orthophoric. Phoria is a state of balance of the eyes when you disassociate the images of the two eyes. So if I was to hold a prism in front of one eye and cause one image to be higher, your eyes would go to a state of rest. So it's called. I think it's more of a more of a barometer of this balance and imbalance between the spatial visual process and that fascia, the motor system, the proprioceptive system, its relationship with the vestibular system. So as we did the study and we found this research, we also looked at visual evoked potentials. And this was one of the subjects. Had a car accident. This gentleman sat in the darkness in his room in the hospital, and he wanted nothing more than to read his Bible, but every time he tried to read his Bible, the words moved on the page. And the moment that he feared most in the daytime, being in the hospital, was the knock on the door and hearing this wonderful, happy voice from a therapist saying, "Come on, Mr. So-and-so, we're going to go down to the gym and do therapy." What was so difficult about that, sir? He said that wasn't difficult. It was going through the hallway and dealing with all the chaotic movement in the peripheral vision and going into a gymnasium where there were other therapists working with patients and everybody was moving about. He said, "I can't take it. It's too much information for me to take." Anyway, this is what his visual evoked potential looked like, which doesn't look bad. So what we did is we took the control group and the experimental group, and we treated them with prism. We did it before, and then we did after. And we hypothesized that the spatial visual process was going to show as a dysfunction between what's called N1 and P1. That's the amplitude. When you do a visual evoked potential, you're showing the checkerboard pattern changing. It's gathering information between these two processes centers, and it's telling you how clear they're seeing by how quickly they make this response on the x-axis between N1 and P1. It's called the latency. But no one has ever paid attention to, or really didn't pay much attention to, what's called the N1P1, which is the amplitude. And we hypothesized that that was where we were going to see our change. And we hypothesized that if we added prism to rebalance the spatial process, that we would see an increase in the amplitude, just like here. Same person, a few moments after the first, we introduced prism, base in prism, and binasal occlusion, 2 strips of tape in the nasal component of both eye fields. Why 2 strips of vertical tape? Because the spatial visual process uses spatial context. And if the person is in post-trauma vision syndrome, they are in a high state of focal regard. Their visual world shifts over from seeing the world like you are now, concentrating to see me, and the rest of the world is diminished to spatial information. They see the world as everything is detail. For those of you that haven't had the experience, I hope nobody has had the experience, you have had an experience temporarily. And I know you have up here. Have you ever driven in a snowstorm at night and by mistake hit your high beams? Suddenly, you were seeing the road before the snowstorm started, the blizzard kicked up, and now you have a meteor barrage of snowflakes coming at you. And these snowflakes become like a meteor barrage of detail, and you lose the road. The road's still there, but you know how hard you have to work to see where the road is to keep your car in lines? You have now shifted over to high focal regard, and you are looking at each line on the road to see where your car is in relationship to it. And you know what that feels like at the end of the day? Or 10 minutes of driving? Well, what if you couldn't get yourself out of that? What if you got home at the end of every day and you said to your wife or husband or kids, "I can't take it anymore. I've got to have some quiet," because it was overstimulating. What happens if you have this condition and you knock at the door of your patient and say, "Come on, we're going down to the busy, crowded environment of our gymnasium to bombard you with more information"? They build up postural tone. They do all the things that you don't want them to do. Now, I'm not saying don't take them down to the gym, but think about this, because it's a component of what you're trying to accomplish to maximize their potentials of improvement, and if they have post-trauma vision syndrome that hasn't been diagnosed and treated properly. Any chaotic movement is focalization. It's a snowstorm. Dr. Ferguson said it this morning and this afternoon about one of her patients, that when he put on the glasses, he said it was like relieving the ability to be in a snowstorm. And you didn't know that I was going to create that as one of my statements. Okay. Well, nobody had mentioned that to me. I just kind of assumed, and I'm glad to hear that it was reinforced by your patient. In the control group, we didn't get the increase in the amplitude. We got a decrease in the amplitude, because if you've got an actively involved spatial visual process with your motor system, and you put prisms in front of the eyes, you're going to knock the spatial system out of alignment. Those amplitudes decreased. So it allows us to look at concussion, traumatic brain injury, and now I know it goes to Lyme disease, tick-borne disease, multiple sclerosis, you name the neurological event. If it affects the spatial visual process, it's PTVS. But many of these patients following a concussion or a traumatic brain injury will exhibit an eye turn outward, exotropia, or a strong tendency for the eyes to turn outward, exophoria. They'll have convergence insufficiency, accommodative insufficiency, problems with tracking and quick eye movements, and increased myopia. These are not causes. Don't treat the convergence insufficiency, treat the patient. You know, don't treat the cold, treat the patient. If we can get over to this way of thinking, you do it all the time as therapists. You're constantly looking for the balance points between posture and organization upright against gravity in terms of support that's needed, and remove the support to gain organization. You're treating the patient. But how many times in optometry, ophthalmology, in medicine, other areas, we treat the big finger, we treat the big toe, we treat the convergence insufficiency. It allowed us to recognize that when you combine this group of characteristics with double vision, blurred vision, particularly at near, seeing objects and print move, headaches, asthenopia, pain around the head, neck, and shoulders of an undiagnosed etiology, hallucinations, because what happens when the spatial visual process locks down and is locked down by the focal process, if they make a move and there's any type of pattern in a carpet or wallpaper, that pattern will move. And not understanding from their cognitive perspective what's going on, they apply some type of an experience. A giant snake, a vertical line, a pole, would suddenly be a snake tied into lines on the floor crawling toward them. Bugs on pizza pies coming toward them to attack them. One young lady went screaming out of a pizza parlor. They delivered the pizza in front of her friends. She looked at it, made a movement, and suddenly the pepperoni or whatever it was moving around on the pizza. She went screaming out of the environment. Pattern rugs in hotels are catastrophic for this population. Any movement that they have, they project into their visual field. The patterns move. I had an elderly woman who lives in a residence, a very fine residence down in Connecticut. And I've seen her for many years and have helped her with her balance. She came in very frustrated. I said, "What's the problem?" I said, "You seem like you're very upset." She said, "You're not going to believe what they did." I said, "Who's they?" She said, "The people over at where I live." I said, "Well, what did they do to you?" She said, "They changed the rugs." I said, "Well, that was nice of them to do. You don't understand. There's patterns all around the rugs. I have a tough enough time keeping my balance. Now I keep getting distracted by all the patterns, and I keep losing my balance." She said, "I've fallen 2 times in the last couple of weeks." This is happening. You know, this happens to these patients if we don't understand it. Photophobia, light sensitivity, is another condition because the overwhelming nature of detail I don't think it's glare sensitivity. I think it's something called dazzle. And dazzle is like photophobia, but it's too much information. And when you go into focal visual processing regard, it's the snowstorm, nighttime, lights on high beams. Yes, sir.
I was just going to say, in that situation, how do you differentiate between her possibly having a vestibular dysfunction?
Well, she does have a vestibular dysfunction. She's been through vestibular therapy, and the vestibular therapist referred her to me because she was still having balance problems. I discovered that she had a visual midline shift syndrome, which I'm going to explain to you. And when we worked in combination between the therapists and the prescription of the yoke prisms, she was able to be fairly independent now with a walker. But even with the walker now, they changed the rugs, and she started falling again. Now, is that a active, acute situation of the vestibular system? I think it's too coincidental, because I hear it over and over again from patients with PTVS that they cannot negotiate areas where there's a lot of reflection, reflective surface. Like, a lot of our stores, hospitals, businesses like to really polish the gleam out of the floor. But the reflective surface brings these type of lights which move with the patient as they walk down the reflective floor. And it's very, very disturbing to them. And that's going to trigger a vestibular response as well as a spatial response. All right, so bring out the vestibular. Let's talk about it. I don't think you can have a vestibular problem without a spatial visual processing problem. I don't think you can have a spatial processing problem without a vestibular processing problem. And I don't think you can have either one of those with having a problem with the proprioceptive system. It's connected. If you go back to the development of the child, one influences the other. Okay. PTVS affects development, cognition, attention, concentration. It affects memory. Well, why memory? Well, think of it this way. The spatial visual process is a filter and a packager. The focal process, all it wants to do is detail. So what would it be like if you went shopping tonight, your way home, and you stopped into the supermarket, you had your cart filled with groceries, you get up to the checkout counter, and you put all the groceries on the checkout counter. Cashier takes it all through, and you're waiting for the bagger to put it all together, and the cashier says, I'm sorry, we just ran out of bags. You're going to have to carry all the groceries out to your car and then reach into your pocket and get your keys without dropping any of the groceries. The spatial visual process organizes relationships. The focal process does not. The spatial process understands the relationships between the detail. The focal process is concentrating on the detail. If suddenly your world turned into detail, how are you going to remember numbers backwards? What's the relationship? How are you going to organize information in your daily life like a phone number? Because it all becomes detail without context. Okay? PTVS dramatically affects motor movement because it causes focalization on detail. Spatial changes. Ambient process becomes an inability to release. The ambient process supports the ability of weight shift fluently, like I'm doing now. When you lose the spatial visual process, the focal process is concrete. The spatial process is plastic. We've read about neuroplasticity. Well, why don't we think about neuroplasticity of the visual process? For some reason, it seems to only affect, we think about it in terms of motor movement and in terms of cognition. But the visual process is involved with both. 70% of all the sensory nerve fibers in the entire body come from the two eyes. It's involved with the plasticity of the visual process to create plasticity in motor and cognitive function. When there's focal binding, that's when you isolate to a detail. Like you said earlier on, you isolate to detail, the world becomes detailed. So when you're trying to track and create eye movements, you become focally bound. Just like, remember, I had you make the shift, asked you a question, and you were all stuck on the finger. All right? This isolation on detail causes an interference with the plasticity of the visual process related to motor planning. It creates perceptual tunnel vision. It becomes more severe in movement. Those patients are perfectly okay if they don't move and you don't move. No problem at all. But how are you going to spend the rest of your life not moving and not having anything else move in your environment? Can't do it. Plasticity of the visual process. It's a collapse. This is a collapse of the response before the stimulus. So if you go back to what we were talking about here in terms of the visual process, the visual process is creating a response before the stimulus. Let's look at a VEP. Here's your stimulus. Here's your response. Stimulus, response. Well, there's a readiness level that's occurring here that enables the visual system to respond. This readiness potential is the spatial visual process relationship to the motor system and its relationship to vestibular and the fascia. Throw it all into one mix. That's happening here. You create the response. Now what do you have to do? Don't get stuck on your finger. You must release. Spatial process takes over. And if it's not a complete release, you produce these strange peaks that are higher than your process. And these strange peaks were looked at in research by the researchers that did the testing monocularly, one eye at a time, not with head injured patients. And they just simply said, well, it's part of the inconsistencies of the visual evoked potential, because they were applying a stimulus response model, not a response stimulus response. When you apply the RSR model, this visual evoked potential under binocular circumstances becomes robust, becomes alive with information to realize that if we're not releasing from our response, we're going to create a series of visual echoes. And some of these echoes are going to be so high, they're greater than the response that we made. If we treat the patient, now we're going to start to at least diminish the echo and increase the initial response, thereby stabilizing. And if you remember, there were 3 lines here. See how they were disassociated? Because the focal response was compromising the effect of the spatial process. Here, we're starting to see this come down to one line, as it's supposed to be, with a much more vertical access to the response compared to here. Look at this gentle slope. This is not accurate. This is a long latency, long time period compared to a very short time period to produce a maximum effectiveness of the visual system. We found this on all the patients. So that many of these patients have double vision, and I was reading over a chapter in Brain Injury Medicine Principles and Practice that I wrote with the other authors, of whom Eric Singman is a neuro-ophthalmologist and head of clinical services for Wilmer Institute, Johns Hopkins University. And I mention that because I know that in the medical profession that there are many that think of this as, well, it's not part of medicine. Dr. Singman is a very well-respected neuro-ophthalmologist. I invited him to be co-author in this book that is 1,300 pages long and considered by many to be the doctrine of brain injury, or at least an important doctrine in brain injury and rehabilitation. In looking at double vision, he wrote this one day to me, and it's in the book, and it says, the clinical relevance of diplopia related to the bimodal visual process is that it may not be enough to consider treatment solely regarding the dysfunction of the oculomotor system and related neurology. When I got involved with Dr. Singman and started to talk with him about my research and my studies, he became very interested, a very brilliant man, very open-minded. And that's how we developed the chapter. And from that, he began to understand the visual process was behind the dysfunction creating diplopia. And he wrote this great context. So I want to go over to looking at a few videos here. We go to 5, right? So I'm going to show you a couple of videos that I hope will bring forward the clinical concept of what I've been talking about more academically. This first woman that you're going to see is a person that was hit by another car in Seattle, Washington. And she was coming out to the Institute about once every few months. And I would work with her, first through diagnosis and then treatment through working with Neuro Visual Processing Rehabilitation. So I'm going to show you a therapy session of, not really a therapy session, this is a treatment session. And I want to bring home the emphasis that Neuro Visual Processing Rehabilitation is a treatment regimen, not a therapy. So I'm going to show you the effect of using lenses and prisms on her as she worked through a very simple activity. I'm going to give her some directions, and I want you to pay particular attention to the way in which she responds to the directions. Hold it 1 second. I want you to look towards the chart that's in front of you. It has letters on it. What I want you to do is I want you to read a letter per step. Walk up to about 2 to 3 feet from the board, and then reverse walking backwards, continuing reading the letters. Did you grasp those directions? Okay. Now there's, 50 to 100 letters on it. She's reading the same letters she just read. Okay, now I'd like you to do that again, only when you reverse directions, continue reading the chart. There's many more letters up there. Don't just read the same ones that you read. No, when you come to the end of your walk, it's like reading a sentence. You don't go back just because you changed the walk. You don't go back and read the same sentence. Just continue on with the line. motor system with the visual processing.
Come back to the room. We want you to just stand facing the chart again. And as you're looking toward the chart, what I'd like you to do is just be aware of your feeling. You can feel yourself standing on the floor. Any different than before? What's weird? So you're now seeing the board that the chart is on, and you're seeing the wall that the chart and the board are hanging on, correct? Are you aware of the floor coming to touch the wall? Now, this time what I'd like you to do is you're going to read this on the letter, start wherever you'd like, and you're going to be walking toward the chart and backward just like you did before. Again, do it again. So what was different? Can you determine why it feels easier now? Let me ask it another way. Are you still seeing the wall? Are you seeing the room?
I love that. She wasn't complaining about the peripheral vision before, but now
And now you're recording interference from the frame from seeing the further. Right? Before you were quite subtle down on that chart. Isolated.
So what happens is the compression of the ambient visual process causes isolation on detail. So the central part of the visual system expands and there's perceptual tunneling that's occurring in the periphery. It's kind of like going to buy a donut. If you went to buy a donut and they handed you this little skinny ring with this giant air hole, you'd say, that's not worth it. You want a nice big fat donut with a little tiny air hole. The prisms do that. The prisms re-expand the periphery and compress central vision. I'm going to put this one on hold. And I'm going to show you another one. So when there's compression of the peripheral space, not in terms of the sense that you see the walls pull in. This has to do with a spatial visual process that doesn't see, but if it can't create context of time and space in the periphery, central occupies the majority of the space. It's like a balloon, constantly finding its balance. So I'm going to put this on hold. And put it on play and move it back. Now this woman was from Phoenix, Arizona. And she was struck by an 18-wheeler, T-boned. She's quite uncomfortable. This is about a year and a half, 2 years into her work. She had surgery done on her neck. She had been through physical occupational therapy. They tried Botox with her too.
Can this last indefinitely without treatment?
I'm sorry, I didn't hear that.
Can it last indefinitely forever without treatment?
Can the condition that you're seeing last indefinitely?
Forever, yeah.
It can. That doesn't mean that you can, a therapist, a doctor, if they can find another road in to rebalance it, you can affect it. But watch what happens here. I'm using prisms because of the spatial collapse. I'm reorganizing through the visual process the relationship to spatial to focal processing. Look at the change in postural tone, abnormal postural tone. Shoulders are down, arms are down, hands are relaxed. Now, that's not a cure. We're talking about levels of rehabilitation. And if you can do this by not putting her on a drug and by not occupying her time for the next 24 months, by a simple pair of lenses, think of what you could do in terms of your work in occupational and physical therapy if you could get her at this level and take her from there. That's what this is about. It's about looking at the interprofessional nature of how we can combine our abilities, our talents, to maximize the potential of the individual. Increased tone will come right back, take the prisms off. Look at the vibration, the tremor that's occurring in her head and neck.
How common is the tremor?
Well, in this situation, it's abnormal postural tone.
So, and then for someone post-concussion who has the prism and still has a tremor?
The question is, what happens post-concussion if a person has a tremor? I couldn't hear everything.
Has prisms, has all the therapy, and still has the tremor?
Well, tremors can be from many different things.
Came on with the concussion.
Came on with the concussion, so there's a neurological involvement. Is the tremor due to just abnormal postural control, or tone, or is it due to some other thing? So tremors can occur like with Parkinson's, such as from compromise to the basal ganglia, the substantial nigra. You know, if there's damage in those areas, sure, you can still have tremor. Please don't think that I'm saying that vision is a cure. It's a rehabilitative avenue to try to bring the person to a new level so that we can all maximize our potentials. Okay? See again, put the prisms on, and there's change in tone. Does this happen to every person? No. It happens to this person, and that's why I'm showing it to you. Because if it happens to this person, it could happen to a person that comes in to see you. All right? I want to move on from this, otherwise we're not going to have enough time. Let's move into the other area of research called visual midline shift syndrome. And this portion is going to be devoted to two research papers, both published in Brain Injury. And the first one was in 2009, where we evaluated stroke patients walking with weight shift, abnormal weight shift. And then we measured the weight shift, and we utilized yoke prisms. And the way we did this, because we couldn't do a double-blind control, because you can't approach a patient with a placebo prism. It's thick on one side, it's thin on the other. There's no way to hide this. So what we did is we treated the experimental group with both left and right prism, and we treated the control group with both left and right prism. So the experimental group did not know which prism was going to benefit them. So we used that in terms of the blind study. In the second study, was we did risk of fall with patients with a variety of different types of neurological conditions, and we measured them when walking on a protokinetic spatial balance test, which accumulated data into a computer to analyze lateral weight shift, anterior posterior shift, as well as vector forces. And then we applied an algorithm to it to take the weight shift and center of mass deviation and convert that into the appropriate axis and power of prism to be used to counter the effects of the shift in center of mass. I'm not going through the research, but we used the prism opposite the base end of the, well, in this particular case, we analyzed first the shift, and then we prescribed the prism. The first study, we used prisms in both directions. The first study demonstrated that we all have this concept like of a spatial domain, a dome over us. And this is a relationship of the ambient visual process to our base of support. And when there's a mismatch of information, we obviously have a shift in weight. And I've developed this formula using X and Y so that if there's compression on the dome on one side, there'll be expansion on the other. This simple formula is an algorithm that will predict the amount of prism. And we also have another part of the formula which predicts the axis of the prism to prescribe it in, because these are not always just lateral shifts or anterior posterior shifts, but usually some type of a combination thereof. We developed a very simple test, and if you take a person and you pass a wand in front of them while they watch it with their eyes and ask them when it's in front of their nose, they should respond accordingly. But if they respond when there's a deviation to the right, often what you're going to see is a shift of visual midline in the direction of the orientation of shift. And this demonstrates that the reason the visual midline shifts is that there's an expansion of space on one side and a compression of space on the other. And you can see it usually in the relationship of the shoulders and the position of the pelvis, where there's an expansion on one side, compression on the other. Just like this woman with a traumatic brain injury. We can also test for anterior posterior by taking a wand and passing it in a vertical meridian and asking when it's at eye level. If they state that it's at eye level and it's below eye level, what they're stating is that they have a shift in anterior posterior visual midline, and this demonstrates an expansion with distance and a compression at near, so that really what's occurring here is that the spatial visual process for the person walking in that direction is saying that the floor is tilted this way and they're trying to become perpendicular to the plane of the floor. Frequently happens with Parkinson's patients who develop the Parkinson's shuffle, and autistic patients that end up becoming toe walkers. If you work with them with the appropriate type of prism, which counters the effect of the expansion and compression of space, the midline will be shifted back, thereby shifting the center of mass back to where it should be. And these people will go into heel to toe gait or shift weight transfer to the affected side. So I've been able to work for years with stroke patients and traumatic brain injured patients and get them to weight bear on their affected side by using the prisms, in many cases immediately. If you had the prisms to be used with your patients in rehabilitation centers, where doctors such as optometrists, Dr. Mandelman in Halifax and other doctors could prescribe these prisms, and you could use these prisms in your rehabilitation centers, you would be able to maximize potentials far greater than what you're seeing now. And I would guess that many of these patients that you're writing plateau with wouldn't have them. So in the research, we proved that this simple test statistically correlates with weight shift away from the affected side, and that with yoke prisms, we could realign the visual midline, thereby realigning center of mass. And we also demonstrated statistically that we could take these patients and create increased weight bearing on their affected side by using the prisms. The yoke prisms realigned visual midline. A prism is a wedge of glass, plastic, or optical media. When used in a lens prescription, you can combine it with a correction for nearsightedness and farsightedness. It's a very, very effective component to not only shift the image, but to balance the effect of the compression and expansion of space. A prism expands space through one end and it compresses space through the other end. But it's much more dynamic than just two-dimensional. It has the opposite effect in a three-dimensional space. So where the apex expands in 3 dimensions in the z-axis, it will compress. Where the base end or thick end compresses laterally, medial-laterally, in the near-far axis, it expands. So if you look at a table with these prisms on, a table would have curvature. And that's what it begins to counter the distortion effect that's occurring within the spatial visual process. The interesting thing is, optometry and ophthalmology have long recognized that a prism shifts the image. But no one has ever asked the question, how does the image shift? The image shifts because the prism expands and compresses space, so literally pushes and pulls an image into a new location. So traditionally it's used to have a deviating eye, measure the amount of deviation, and put the prism in to shift the image over to where the eye is pointed. We're using it differently in rehabilitative optometry. We're understanding the distortion that's occurring in the spatial visual process. And what we're doing is we're organizing the relationship of that compression expansion to be countered by the effect of the yoke prism. The other interesting thing here is, in ophthalmology and optometry, I've long heard this criticism that yoke prisms don't work because the visual system adapts to the shift of the image. What visual process are they asking the question for? You know, I think like a researcher. And if you're not asking the right question, you're not going to get the right answer. Well, when they make a statement that it doesn't work because the visual system adapts to it, what process are they stating? If the image shifts, they're only dealing with one process, the focal process. The key here is that the image shifts for only the focal process. The ambient process doesn't see an image shift. For the ambient process, what occurs is a weight shift away from a central fixation point. That's what creates the weight bearing on the affected side. Sure, for the focal process, it adapts to seeing the image shift. So if you use the prisms and keep reaching out for the target, you suddenly get to the point that you can grab it, because initially you're out here and you come in. Focal process adapted because of kinesthetic tactile information coming in through the spinotectal tract, relayed from brainstem to the superior colliculus to 99% of the cortex to reestablish spatial mapping with the prism on. Focal process. Ambient process never adapts. It always increases the weight shift off to the base end side. This is the key to understanding that doctors practicing neurovisual processing rehabilitation and neurovisual postural therapy utilizing prisms can make significant changes with postural organization and balance because of the fact there are 2 visual processing systems. Not stimulus response, it's response, stimulus response. And when using the prisms, we are reestablishing the spatial relationship of the response before the stimulus. Any questions to this? There's a young child with cerebral palsy before the prisms, a few seconds later with the prisms. This is the map that I'm measuring the imbalances on now. This is a person that was referred to me by a physiatrist that after a whiplash, she developed a stumping effect and almost like a hemiparesis to the right side. Physiatrist tried Botox, also tried physical therapy. She was finally sent in to me with this pattern of movement immediately upon putting on the prisms, heel to toe. So it was abnormal postural tone that was creating the imbalance on one segment or one orientation of her body. The prisms affected that. This is her walking pattern. This was the cyclogram before, and this is the cyclogram after. Still not perfect, but far better. And this is what it accumulated data on. I've got to move forward here if we're going to get to some good stuff. So think of this. Sherrington said, if movement follows posture like a shadow, then think of this. Vision is the mirror of posture. Posture is the mirror of vision in the spatial context. And movement is the expression of the combined potential. And we can only get there by working through the spatial process and through the motor system. So the center of mass we know is somewhere around the navel in the adult. And when walking, we should do a weight shift, but pretty well maintain the position of center of mass. But when there's a deviation, we can see that it's also going to affect weight bearing. The center of gravity works through the center of mass. The center of gravity is slightly higher than your waist, and it's organized to be able to maintain stability. So long as the center of gravity doesn't shift beyond this base of support, you're okay. If it shifts beyond this base of support, you're going to topple. We can do demonstration, but I'll leave this to you. You can stand upside, lean to one side, now quickly reach for a point. Your body feels like it's going to topple over. You make a series of compensatory movements. The lower the center of gravity, the more difficult it is to topple something. Gravity works on the body like a sack of potatoes. So the body has a center of mass, a center of gravity. But if you have a sack of potatoes, each of the potatoes has a center of mass and a center of gravity. The closer you get to deviating the center of gravity, the more the individual potato center of gravity starts to act like an individual force. And what occurs is, as you move to a point distal from a centered equal weight-bearing point, each portion of your body starts to create a different center of gravity, which creates organizational components and a wheel-like effect that happens in the ankle opposite the shift, so that you can now remain upright without toppling. I didn't do such a good job that time, did I? The taller the sack of potatoes, the easier it is to push it over. Likewise with a human. Okay, I think I already said this. If you draw a perpendicular line, once that perpendicular line from the center of gravity is outside the base of support, you're increasing risk of fall. The greater the shift, the wider the base of support. So that's why you see the young child who comes up against gravity, wide base of support, and no trunk disassociation and head and neck disassociation. They walk like this. Just like an elderly person that starts to lose spatial organization with proprioception, a person with concussion, traumatic brain injury, Parkinson's disease, multiple sclerosis, Lyme disease. They'll all do that. This torque that's involved of the upper body, like the sack of potatoes, acts now like a lever effect. And the lever effect is what starts to create restrictions of lateral extension and lateral flexion. So the body now starts to develop abnormal postural tone and restricts weight shift, movement around the trunk and head and neck. I think you had a great example during the break where you talked about the child you worked with in hockey, or put the child on skates, and now all of a sudden the kid was trying to hit a hockey puck, but everything locked down. The child developed the lack of ability of head on body and the lack of ability to organize trunk on body, and developed probably a very wide base of support because the base of support became unstable on ice skates, on ice, and the child now became rigid. Well, this happens all the time with the patients that we observe. Yoked prisms can affect the center of gravity by realigning the center of mass through the visual process of organizing a shift of visual midline back to center by compressing, expanding space through the use of prescribed yoked prisms. If you use the prisms incorrectly, you're going to do just as much damage as not using them at all. Well, I shouldn't say it that way. By not using the prisms correctly, you're going to create inappropriate weight shifts. If you want to use a prism to affect a person in this posture, well, you would use a particular type of prism if all you were looking at is the upper body, seeing leaning forward, you want to make the person upright. But if you didn't pay attention to the fact that I'm on my heels and I'm leaning forward in this tight component, to affect that if I stood up, I would lose my balance backwards. Well, if you don't understand posture, don't prescribe the prism for that person, because if you prescribe it incorrectly, this person's going to fall backwards and get a head injury. The displacement of the center of mass is like the Tower of Pisa. The moment the center of gravity goes beyond the base of support, we lose a famous piece of architecture. The lever effect is very much like this bottle on this lever. The center of mass shifts to be directly over a point, and now the ankles, as you're creating the lever component, now act as a pivot point. And that's what we do when we change direction. We're using this concept of center of gravity shifting, and we're using this wheel effect in the ankles to create shifts in posture. So for the child, the center of mass is very low. But as we grow older, it moves up to L5 and S1. So here's a child just getting upright, wide base of support, rigid trunk on body, and head on body. But now take a look at this baseball player, and the relationship of the center of mass is the point of initial stability that allows this baseball pitcher to create a one-point contact with the base of support and do weight shift through shifting the center of mass, which still remains stable over the base of support, so much so that follow-through of movement reaches its maximum potential when the center of mass is stabilized with the center of gravity over the base of support. If there is disassociation, it would not enable that pitcher to maintain posture, balance, and movement to throw the 95-mile-an-hour fastball. These are some pictures. We can now utilize, let's show a video of a visual midline shift syndrome, and then I'd like to go into neurovisual postural therapy. So we can utilize the yoke prisms very much like thinking of a lever to rebalance the process coming through the visual system, but realize the spatial visual process is not a seeing system. It acts more like a proprioceptive system. And proprioception is our forgotten sense. Proprioception is a sense. But we don't talk about it because we don't think about it. We think about ears hearing, eyes seeing, taste tasting, touch touching. Proprioception is a critical sense, but not in the sense of experiencing, well, we did see this guy, didn't we? So we'll pick it up from where we left off here. 1 second. Let me finish my statement. But not in the sense of a feeling sensory experience. It's a proprioceptive experience only against gravity. And the spatial visual process is very much a component of this experience, not in the sense of seeing and sensing something. Okay. So let's take a look at Mark as he continues to walk. I don't know who that person is, but vaguely familiar. I'm putting yoke prisms on Mark. This was a complete spatial visual processing distortion. No wonder doctors couldn't find a brain injury. They couldn't find anything wrong with his muscles of his eyes, the nerves, because that's not where the processing problem was. It was a mismatch between the spatial visual process, the vestibular system, and proprioception. He wanted to wear these glasses for the rest of his life. I said, no, 2 hours a day with these funny looking glasses, a regular pair of glasses with a moderate prism. I wanted him to come in for additional work. He could only get in occasionally. Every time he came in, I would readjust the rotatable prisms because the midline coming back to center will take funny shifts, forward, backward. And the rotatable prism gives me the ability to constantly rebalance it without prescribing glasses. Take the prisms off, look what happens.
How would he have been with his eyes closed?
Still had problems.
Same amount of problems?
He still had problems. This was a mismatch in the proprioceptive system, the vestibular system, and when you close your eyes, you still have mismatch from the extraocular muscles and the experience of the spatial visual distortion. Yes?
Can you repeat what the prism types was that you may have already said it and I didn't catch it, what the prescription was?
He was using a very, very high prism, over 15 diopters of prisms. You wouldn't want to walk around with it. I have a pair here. If you want to experience it later on, you'll feel what he did. Because you don't have a compromised proprioceptive system doesn't mean you're going to fall into a wall. He did. But that boat falling on his neck and shoulders was the problem because it dismantled the relationship between the spatial experience and his proprioception, and vestibular now was completely out of control. So here's a patient that if you worked, and they even gave him physical therapy, they gave him vestibular therapy, it didn't get better because it couldn't organize itself without this main component occurring through the visual process. A year and 3 months later, I saw him, and that's the last time I've seen him. I prescribed a regular-looking pair of glasses, down now from over 15 to 1 diopter prism. It's a little bit more of an angle than a window, okay? Flat, maybe not completely flat. And I haven't seen him since. Now, I'm assuming that this was a cure. Not many of my patients get cure, they get maximum potentials. Same thing again. So I don't claim to cure, I rehabilitate.
So he would benefit from the ocular vestibular therapy after the prisms, though?
I'm sorry?
Would he benefit from the ocular vestibular therapy after having the prisms? So would you suggest people go get the prisms first and then try that therapy?
Well, he didn't need it.
Okay, so some people just won't need it, but if they haven't
Yeah.
responded well, then you
But
would
his
suggest-
problem was primarily in the distortion that occurred in the spatial process, disconnecting the relationship from vestibular to vestibular. In his case, those were systems that were intact, but they couldn't reorganize themselves without the spatial process. So now what happens if you do have a person where the vestibular system is out of balance and there's a proprioceptive? If you're going to have that, you will also have a spatial processing problem, visual processing problem. You know, there are people that you can work with through vestibular and they get better. Is it 100% better? That's for your judgment and the person. There are people that we work with through vision and they get better. Is it 100%? As well as PT. Wouldn't it be great if we could start to work together and say, if we're going to do vestibular, let's get the visual system in balance and the myofascial. I mean, that's the perfect way of dealing with it. Yes?
Let's say you get someone who has like 10 diopters or something in their prisms and they need a treatment, so they come and start some MPPT, and you're seeing marked improvements, right? So obviously they would need a reduction at some point in time. So when you're looking at the reduction, how long is too long to wait in the sense if you see it, like can it be detrimental if you're waiting more than a month, 2 months?
How often do I see the patients with prisms?
Yeah.
Well, it depends on where they live. So if they're coming to me from Trinidad, I don't think I'm going to see them a week after they leave.
That's kind of what I'm at.
So what I do is I keep fairly close communication with my distant patients. I don't have anybody I can refer to there. I'm sure they're physical therapists. But I'll work with this patient intensively for 4 or 5 days. And I probably will bring in PT and OT or whatever else I need to fortify what I'm trying to accomplish with this patient. I brought in a physical therapist into the institute. She has her own office. When I get a patient coming in, I tip her off and saying, this guy's coming in, I'm going to need some time from you. And she'll see the patient. We work intensively for a week or so, and then we move the patient on. So I'll prescribe the prism, keep in contact. If some point I hear that something is going wrong, I try to problem solve. Send me a video, let me see the patient walk. What's the posture in a wheelchair? And if I can't figure it out there, then we know we have to do something by either bringing the patient back or getting the patient to some doctor that can at least follow through. Sometimes it's not a doctor, oftentimes it's a therapist that can give me more information about what's going on. And if I can't get the patient back, I'll try to do something through another professional. Okay. So vision is motor. A.M. Skeffington, he was an optometrist. I don't even think A.M. Skeffington knew how profound that statement was. But vision is motor, so behavioral optometry was developed in order to try to deal with it. So what did we do? All we knew was, let's get the kid on a balance board, let's do jumping jacks, let's do cross pattern movements. Great, it worked for some kids, but not this population. This population is not a generalized population that you can say, here's the cookbook, take it, run. I have optometrists and ophthalmologists are saying all the time, yeah, but just tell me, give me the cookbook. There is no cookbook. That's why I did a 50-hour course. That's why I'm here talking to you in terms of an interprofessional group, because it takes this model to bring this forward, to get these type of changes with patients. Now I'm showing you the dramatic changes. I have a lot of non-dramatic changes with patients, minor changes, that I'll call Donna up, the physical therapist, and I'll say, I've got a patient, I need your help with this patient. Or I'll call an OT or a physiatrist up, or somebody else, psychologist, says, I need additional support with the patient. Let's look at posture and movement. Neurovisual postural therapy is something that Raquel Munitz and I developed. She's an incredible therapist. She worked for 30 to 40 years with Dr. Christine Nelson. She also happens to be a psychologist. She doesn't practice psychology, but her depth of knowledge and understanding is extremely broad. We developed an understanding that neurovisual postural therapy requires the need to create facilitation of movement in a very controlled, precise manner that will start to engage the spatial visual process. And facilitation is the key technique used by the Bobaths for practitioners to facilitate change with children with cerebral palsy. The key component here is we not only need to facilitation of movement, we need to create inhibition of movement. Same thing with the visual process. If the person is over-focalized, what we need to do is not only rebalance the spatial visual process, we must create inhibition of the over-focalization. Nobody's talking about this in terms of visual process, but when looking at the ambient visual process and it's out of balance, it's like a house of cards that collapses. The focal visual response is to bind and repeat, become repetitive. You have to not only facilitate reorganization of the ambient process, you have to inhibit over-focalization, just like you would do in physical and occupational therapy to inhibit a movement to get an engagement of weight shift. Am I correct? No different. The key points of control here are that we have to recognize that there are proximal points of control and there are distal points of control. And neurovisual postural therapy requires hands on the patient. When I say this to optometrists, they say, what do you mean? I have to touch a patient? I can't touch a patient. They're going to sue me for touching a patient. Well, you ask permission first. And you say you're going to touch your back, you're going to touch a shoulder, you're going to touch a limb. and you facilitate the weight shift. You do it as physical therapists. Optometrists need to do this too. And we utilize these proximal and distal points of control in order to facilitate movement and weight shift. And here are different postural variations. You can see anterior, posterior shifts, a wide variety. As an optometrist, if you don't understand what these relationships are, that this could be an anterior shift with hyperextension because of increased weight shift forward. This can be too much weight shift posteriorly with a flexion forward. And eventually, where does kyphosis come from? Is it just some inappropriate imbalance that's genetic? I don't think so. But anyway, another story. So in the course, I have a series of these slides, and I'm going to take you through this rather quickly. So erect posture, upright against gravity. We have shoulders in alignment. Pelvis is, I always think of the pelvis as a mirror reflection of the relationship of the perception of the horizontal plane. And if you have anterior, posterior shifts, lateral shifts of the pelvis, it's giving you a good idea of what's going on with the spatial process. When there's an unequal balance between weight shift, where you're seeing increased weight shift with increased expansion of space between the shoulder and the pelvic girdle, you're going to usually have a weight shift to the outside border of that side with a compression of space on the opposite. A left posterior weight shift might look something like this, where you have a shoulder higher on the left, pelvis tilted down and backwards, increasing weight shift to the left heel, and a lot of imbalances with postural alignment, compensatory strategies of the upper body, and increased abnormal postural tone here and on one side. A posterior weight shift will be weight forward with a leaning forward of the upper body, anterior upper body inflection. A visual midline shift, posterior weight shift from the posterior view will be demonstrated with the weight shift backward and the leaning forward. So as an optometrist, if you don't understand posture, don't prescribe the prism unless you're working with PTs and OTs that do. Therapists, I don't know what the laws are up here, but in the United States, you do not have license to utilize prisms. If you start to utilize a prism and a patient falls, you're going to create legal liability for yourself as well as for the hospital or rehabilitation center. So I'm not saying you don't have the understanding of using prism. I'm just bringing out the legal implications here. Optometrists do. If you have optometrists that are willing to work with you, create the team. So an anterior weight shift often produces scuffing, shuffling, Parkinson's, toe walking posture, and it might be leaning forward with upper body extension to counter the effect, because the sack of potatoes now is going to start to create a lot of strange torsion components. Anterior weight shift from the side view will show a lot of extension posture and abnormal postural tone in the neck and shoulders. Neuro Visual Processing treatment approaches can utilize lenses and prisms to counter this posture. Neurovisual postural therapy is the facilitation of developing visual postural changes through the use of yoke prisms by facilitating movement in the longitudinal and lateral extension and flexion axes, also to establish the development of visual skills. It's a new therapeutic approach that I've been working with Raquel on, and I give her credit because she brought this forward to my attention, and she said, look what can happen. And when we introduce this to populations of patients that have post-trauma vision syndrome and work with the prisms and do not do fixation therapy, what we see is in a very short period of time, convergence insufficiency will diminish and go away by itself, as well as improvement in therapy. I had a patient in last week with a receded near point of convergence out to about 14 inches from a concussion. And I started the use of the prism lenses one day. Came in, it was a better posture, still had a receded near point of convergence. I started one session of therapy with this patient, checked the receded near point of convergence, worked through neurovisual postural therapy, checked it at the end of the session, he converged into 5 inches. One session. No fusion therapy, no pencil push-ups. I am convinced that everything I learned in optometry school about binocularity was only a piece of this puzzle. And that what we need to do is we need to combine the understanding that you have with the base of support to truly understand the nature of visual skills from a developmental framework as also from the pathological issues from head injury, traumatic brain injury, and neurological events. So when there are unstable fixations, poor quality pursuits, we have to look beyond that. So this is a patient that I had in Mexico. And obviously, this patient is very much involved. So he had very poor quality. He has an extended left shoulder elevation. Right shoulder is depressed. The trunk was shorter on the right side. The weight was distributed to the right side. Head orients to the left in compensation. Neck was shortened on the right side. The legs were internally rotated. There was no dynamic weight shift loading from the feet. So we started to develop some neurovisual postural therapy. And we brought him to his knees and gave him support with a roll. And you can see the increased abnormal tone that this young man has had since his injury, which was a traumatic brain injury. And what we're doing with him is we're avoiding overfocalization. Any overfocalization is going to interfere and interrupt the fluidity of the spatial visual process. The response of the postural control will now create more plasticity if you can start to organize fixation changes in conjunction with lateral weight shift. We're using the goals for this session to establish efficient eye-hand coordination and fixation release, not fixation. Think about a black and white negative, old black and white negatives. Well, you know, it's just the opposite of what you see from a photograph. That's the way we have to think about vision. We have to start to think about vision not in terms of focalization, space. We have to think about it in terms of the spatial orientation, the ability to release from focalization, inhibit focalization, and reestablish fixation. So what Raquel is doing here is she's created an organization of stability in the base of support, 2-point contact. No, more than that. He's on his knees as well as has contact with his toes. So it's 4-point contact. And she now is developing trunk rotation with a saccadic fixation and organization of eye-hand coordination to that point of fixation. You have to work with little tiny targets. And now he's shifted to the other side. This was a major event for him to be able to organize that. This young man, when I went down there to work with him in the clinic, I said, you know, what are the problems? I said, well, he can't feed himself. I said, what do you mean he can't feed himself? Well, he keeps missing his mouth. So I said, okay, let me see. So they gave him a spoon with one of the bands, and they said, okay, come on now, look. Missed his mouth. They said, see? I said, well, you're creating the problem. They said, what are you talking about? I said, he's not supposed to be looking at the spoon. He's supposed to be looking away and using the ambient visual process to coordinate the spatial organization of midline and to develop the freedom of movement as opposed to the focalization which got him to miss. We then had him look across the room right to his mouth. You know, it's logical if you understand the bimodal visual process. You can affect hemiparesis, quadriplegia, diplegia. You can work with congenital, acquired, abnormal postural tones. You can work with weight shift through prisms and neurovisual postural therapy. You can affect this in a non-invasive way through a simple set of lenses and prisms that can make major changes in a person's life. If there's a strabismus following a person, let's say you have a person with a traumatic brain injury, and this person comes into a hospital complaining of diplopia, do not patch the eye. When you patch the eye, you create a visual midline shift, and now you're going to have problems working with the patient in rehabilitation. Get an empty pair of eyeglass frames if they're not wearing glasses, and take simple tape, transport tape if you have a hospital, and build it out from the nasal component just far enough to block central vision, but keep ambient spatial visual processing open so it allows it to start to match up with proprioception, called central occlusion patching. We talked about all this. In conclusion, neurovisual processing rehabilitation is a new model emerging in the field, and it's involved by looking at the bimodal visual process in relationship to the base of support and vestibular and proprioceptive systems. NVPT therapy is a specialized program designed to be used in conjunction with neurovisual processing rehabilitation after the prescription of prisms. I have had a therapist take the course. I have a wonderful therapist. She's excellent. And she's been writing to me in frustration in Montana saying, I see what I need to do. I can't get any of the optometrists to do it. I have been trying to get an optometrist to just drive over the line and just work with her a little bit. So now what she's done, we've connected her with an optometrist about 150 miles away in another state, and she's trying to get the patient over to there. Visual midline shift syndrome and post-trauma vision syndrome are real syndromes. These are affecting people every day, more so than you realize. Matter of fact, most everybody in your practice has some component of these syndromes. When I go out with my wife shopping, she says, will you stop that? I said, well, did you see that person over there? I went to a tennis match, and we're sitting watching the American #1 doubles team against a challenge match. And we had great seats, and I'm watching the players playing in the #1 tennis match, the #1 team. I said, Judy, I said, look at, she said, stop it now. She said, don't bring this to the tennis court. I said, yeah, but look at this guy. I said, the #1 team is going to lose the match. They won the first set. Then very quickly, the other team picked up on the fact that every time he was at the net and they hit a hard ball to him, he would shift into an anterior shift to midline, throw his pelvis forward, go on his toes, and drive the ball down into the net. They lost the next 3 sets. It's happening in sports. It's happening all over the place. Plasticity is what we're after. It's compromised when you have post-trauma vision syndrome. Through neurovisual processing rehabilitation, we have a new frontier model. We have a way of applying a stimulus response model to application of movement and posture and balance. Together, if we work in bringing forward this model, we will have new levels that we can bring patients to maximize the potentials, have less of a chance of writing this patient plateaued. Are there some questions? Yes.
There's a lady that I've been working with post-concussion, and when I do the vertical midline, she always says it's here. But when she stands, she seems to be forward.
Okay, so this test I don't even use anymore. I gave it to you because it's a simple way of understanding it. However, if you're getting this, that's a posterior shift. So I'm in a posterior shift right now.
Yeah, her hips weren't back. She
It doesn't mean it has to be exaggerated. I'm in a posterior shift now, and my hips are over my heels. It just simply means you're an optometrist. No, physical therapist. Okay.
Her weight is anterior over her ankles. I just wondered if you get like a pusher syndrome.
Okay. Well, then that test is not an accurate test. If you observe posture and you, as a physiotherapist, are seeing that this person is weight shifted posteriorly, yet she's giving you some strange response, she's overfocalizing. That's why it's a relative test.
She was seated for the.
Yeah, she's
Oh.
And she was standing for the other dynamic.
Oh, okay. Well, obviously, it's two different tests, seated, standing. It's always good to do both. I rely on observation of posture. So I've been doing it for 30 to 40 years. I'm pretty good at it. It takes time to really learn that. So I would rely on your judgment of postural alignment. Relay this to the optometrist. Tell her what you're seeing. Okay? Yes, sir.
What about someone that's not an injury, a neurologic injury, but they're born with amblyopia, and you're noticing some things like that, some
Okay.
odd.
So what happens when a person is born with an amblyopia? So an amblyopia is going to create a displacement of the visual midline, especially if there's a strabismus involved. So if there's a displacement of the visual midline, that midline will reinforce an abnormal postural shift. So hitting a baseball, no matter what it is, hitting a puck, walking, running, there's always going to be a distortion there.
So if you see them when they're 30 years old,
I just worked with the dean of, I can say this because he gave me permission, the dean of School of Graduate Architecture for the RISD, Rhode Island School of Design, very well-known architectural school, had diplopia his whole life, even had strabismus surgery at a younger age, continued to have surgery, have diplopia. I worked with him and he's in his 50s. He now has single vision and binocularity, 3D. And he just sent me an audio visual, which I was telling the doctor about, where he was invited to be a storyteller at one of these clubs because they were doing brain injury, storytelling. And he sent me this remarkable discussion of what it was like to have this experience with double vision and what happened to him the moment this began to come together. He broke down crying when this experience occurred, when he started to get his world back together again. Age is not a factor. I know they say 6 years of age, 10 years of age. The Chinese now have evidence working with 30 and 40-year-olds that they can correct strabismic surgery. I have worked with 60 and 70 years old and corrected strabismus surgery. It's just if you don't ask the right question, you're not going to get the right answer. And that's what's happened with our research. And maybe if we don't want to ask the right question, we won't get the right answer. And that's what's happened with our research. Question?
Is there much research out there at this point in terms of the postural therapy that comes post-prism effectiveness, like there's the effectiveness from the prisms, and then the postural therapy following that? And if there is it specific to your training program, and does it compare to, say, other therapists who've had other sensory motor training, NDT training, that sort of thing, and a comparison?
Good question. The question is, is there any research looking at the neurovisual postural therapy and the effect it has on patients? And then the second part of that question is, what happens if you apply NDT or sensory motor or other experiences?
Or how they compare?
How they compare to it? Well, it's a good question, and no, I don't have an answer to that. NVPT is a relatively new model and approach, but it's like saying, well, vision therapy doesn't work. Doesn't work for what? Well, optometrists have proven that they can take a patient who has a convergence insufficiency, not the ones we're talking about, and they can improve convergence insufficiency. Dr. Mitch Scheinman from Salus University developed a very interesting research study. And he said, I'm going to prove that convergence insufficiency training through fusion can be trained better than with pencil push-ups. Guess how much money he got from the National Institute of Health? $5 million to prove this, all right? Did we need to spend $5 million to prove that vision therapy works? But what does it work for? Neurovisual postural therapy is the same. To say, does it work on what? Are we trying to create rotation? Are we trying to create saccadic fixation? Are we trying to affect convergence and sufficiency? So we must ask the right question. Then we can design the research model. And quite frankly, I just haven't had time just yet because I've been doing other research, which I showed this morning. But it's in my game plan. And can you apply other modes of therapy? Sure you can with the prisms. We're using neurovisual postural therapy because it's very, very precise in stabilizing the base of support and always making sure that the person comes forward from a stable base of support. So if you're going to get a child in sensory motor integration and you're going to start flipping this child back and forth on a scooter board, it doesn't have a stable base of support to try to get visual interaction in the vestibular, that's not going to affect the child's posture, nor is it going to affect convergence, because convergence comes out of organizing stable base of support with flexion. So we have to think about what we're looking for, what is the question that we're asking for, and how are we designing the research model for it years to come. Any other questions before we depart? Yes.
When you were working with your Parkinson's patients,
Yes.
did glasses have any effect on the freezing of the gait?
Freezing of the gait?
Yeah, did it stop
Yeah.
the freezing?
Very much so. What I found was, and this is anecdotal, I don't have this research. I mean, I'm a clinician, but I love research. So I do my research from 11 o'clock at night to 3 o'clock in the morning, writing the papers, looking at the statistics, and, it takes more time than if I were an academician in a university such as Dalhousie. So what we're doing with this is we're looking at the relationships of how we can change these postures and movements. And then if we can break it down into components, then what we can do is look at it from the research model. And I think that all these things are possible. I think now that we have a model of rehabilitation to come forward with and start to look at the changes that we're getting anecdotally, we can make changes and make predictions. For Parkinson's disease, when there's an anterior shift, you're creating excessive flexion. They're fixated on the ground in front. They're not using the spatial visual process to anticipate change. What happened to you when you got stuck on your finger when I asked a question? I did it purposely, I brought you over there. I asked you a question because I knew I was going to engage your focal process through cognition. I got you all stuck. Well, if the person gets stuck on a point in space, if you spend your whole time looking down, you're going to be stuck. You're going to develop the same posture of a Parkinson's patient, and when the focal system jams, the motor system freezes. How many times have you had a patient in therapy, stroke patient, Parkinson's patient, you say, okay, Mr. So-and-so, Mrs. So-and-so, walk. And you see them grimace, and they can't move, and you have to walk over, grab a leg, you get the movement, and all of a sudden they start moving. Focal binding. If you get the Parkinson's patient to look up without prisms, you'll break the focal binding. Or pass your hand in front of them. Do anything to disrupt the focal binding, they'll move. Better yet, prescribe the prisms that rebalance the spatial process and then start to create the organization of fixation ahead, and you won't get the freezing. The freezing is a focal binding. You are a great audience. I've really enjoyed this afternoon as well as this morning. I thank you so much for this invitation to come here, and I wish you well. I hope that you really do develop this consortium of working together in this very exciting area, bringing together neurovisual processing rehabilitation with NVPT and your professional disciplines. Thank you.
I also wanted to personally thank Dr. Padula for coming and almost donating his time for his visit today and his lecture to us, and throwing the gauntlet out there at the optometrists and therapists, I would say throughout the Maritimes, and see if we can develop a true multidisciplinary model and be the first of its kind in Canada. Yes, and thank you very much, and a little gift for our. Thank you.